in that one moment, when a life hangs in the balance, what you do next can change everything. And yet, so many of us are left standing there, helpless, clueless, wishing we had the skill, wishing we knew what to do, wishing we could reboot a life. Meet Dr. Basavaraj Kuntoji, an ICU intensivist with a relentless drive to save lives. Not just in the ICU, but out in the world where emergencies strike without a warning. Dr. Basavaraj completed his MBBS from Rajiv Gandhi University of Health Sciences, Karnataka. He went on to earn his MD in General Medicine and later pursued specialized training in critical care with the Indian Diploma in Critical Care Medicine and the prestigious European Diploma in Intensive Care. But more than just a physician, Dr. Basavaraj is a passionate educator and a life-saving advocate, dedicated to training others in essential emergency response techniques like BLS and ECLS. Because according to sources, in India, 1,600 people die every single day due to sudden cardiac arrest. That is more than one life lost every 60 seconds. And in over 90% of these cases, CPR is never performed. Not because it wouldn't help, but because nobody knew what to do. To change that, PRS Neurosciences, in collaboration with Dr. Basavaraj Kuntoji, has launched this vital initiative called Rebooting Life, a campaign aimed at CPR training and public awareness. On April 30th, the first training session took place, equipping a new wave of trainers with the knowledge and skills to save lives. It was more than just a session. It was the start of a movement. Because saving lives should not be a privilege reserved for a few, it should be a possibility for all. This is Rebooting the Brain, and this episode might just help you reboot a life.
Jnananandamayam Devam Nirmala Spatika Krutim Adharam Sarva Vidyanam Hayagrivam Upasmahe Adharam Sarva Vidyanam Hayagriva Upasmahe Hayagriva Upasmahe.
Rebooting the Brain, powered by PRS Neurosciences. Namaste, everybody. Welcome to yet another edition of our podcast, Rebooting the Brain. And I shall start with my shloka. Om Asatoma Sadgamaya Tamasoma Jyotirgamaya Mrityorma Amrutam Gamaya Om Shanti Shanti Shanti. This shloka has always been an inspiration for me from my childhood. And as the shloka says, from darkness to light, from ignorance to enlightenment or truth, and from death to immortality. You can use these phrases anywhere in your life and see how you can adapt to become a better human being. I am Dr. Sharan Srinivasan. I'm a stereotactic and functional neurosurgeon from Bengaluru, India. And today, before I go to the guest of the day, I want all of you, a lot of people have been reaching out to us saying that they've been loving our content. And I promise you, I don't think there's any other podcast channel in the world churning out this quality of medical content to the common man in a way that you understand. So if you're liking these things, please share, Please subscribe to our channel, hit the bell icon, and definitely press the like button. And be generous in your comments because you never know where it'll help. Remember that we also have a documentary called Rebooting the Brain. Please look for that and do that. Go through those episodes. We also have a book called Rebooting the Brain, which was an Amazon bestseller. Please search for that on Amazon. Get your Kindle copy or your hardbound one, whichever you like. I like hardbound ones. I'm still an old-fashioned reader, and you never know what more information that you get which can help a loved one. So let me today go to the guest of the day, a dear friend of mine, Dr. Basavaraj Kuntoji. He's a guy who wears multiple professional hats very successfully, a dear friend since the year 2009. We have had so many, professional times together, and thanks to, us working together, so many of patients' lives have been saved. And today we're going to talk life and death, hardcore life, death, complications situation. Dr. Basavaraj Kuntoji, he's an intensivist, okay, and also a physician. So Dr. Basavaraj, he works at the Manipal hospitals and the Jain hospitals with me. Dr. Basavaraj, welcome to our show.
Thank you.
Long distance shake hand.
Yeah.
I hope I have not missed anything in the introduction that you wanted me to tell the guests.
No. Thank you so much for the introduction. Sharan.
My pleasure. And I was waiting for a long time to have this chat with you because there's so much we have shared together. And I think that a lot of what we have shared together should go out to the public because then they will know that what is possible, what is real, what looks impossible, and things like that. So as you saw, this video started with two videos of stories of a child and adult who had a cardiac bar respiratory problem, and somebody in the public did CPR. And these people are not only survived, they are back in their life. Now, I don't know how many of our audience even know CPR, the phrase and what it stands for, and how does this work. So can you educate our public on CPR, what does it stand for and everything else?
Okay, to tell you, to start with an example itself, like what I did mention that, yes, when I was in a Goa and along with my family.
Goa,
yeah,
the beach resort.
The beach resort along with my family.
Mm-hmm.
And suddenly I could find that a lot of noise started coming, and we could see that around 3 or 4 family members of the same family getting drowned.
Yes, in the sea?
Yeah, in the sea. Out of which 2 were literally gasping and they were about to die. So since I was a trained BLS as well as ACLS trainer, which is day in and day out my job, so then I know that what needs to be done. So started giving a chest compression. It's difficult to give a breathing also, but at least made him to lie down. And I know that pulse was feeble, but he was gasping. So till the ambulance could come, so I continued giving him chest compression. And yes, the ambulance did arrive. I could go into the ambulance also giving chest compression and made him to reach the hospital. There he got intubated. And yes, I was away from the family at that point of time. Family was worried that why this guy is doing all these things, but
on a holiday.
Yeah, on a holiday. So I could not stop it. But yes, it went in. Family said you could not have done, but I was happy on that day. But the realization came maybe after 6 months when I got a call from the family saying that yes, they didn't know that I was a doctor. So okay, we came to know that you are the one who's saved my life. So that helps me. That makes me that yes, what the CPR can make different. Unfortunately, the other family members on the same day could not survive because they could not get the appropriate CPR.
So there are no 2 Basavarajas. There's only one Basavaraj on that. But 2 people needed the same attention.
Yes. At the end, it is a training what matters. So that's what at the end the CPR. What you asked is it generally we initiate when the heart stops.
Hold on. Before you do that, what is CPR?
Yeah. So it is called as a cardiopulmonary resuscitation. So
cardiopulmonary resuscitation. Cardiopulmonary, heart, lung. Resuscitation means getting them to function back or work back if it has stopped working. So it sounds very simple. It's not as simple. Yes.
So that means generally we initiate this cardiopulmonary resuscitation when we say that suddenly if somebody becomes unresponsive. So as for the BLS protocol, we say, hello, are you okay? Are you okay? That means we'll tap, are you okay? If he is unresponsive, so immediately we'll ask for a help, or we'll ask them to call for a code blue.
Now this hello, are you okay will happen if you are called.
Yes.
Now the public should realize when somebody is not responding, what is going on. They should realize that something has happened. No, if that the first key, guys, you have to understand is that the person doesn't look okay.
Exactly.
You know,
Yeah.
many people are, nobody even cares today. Somebody is dying, they're taking videos today. You know, it is crazy. So you left your call of duty of with being in a family on holiday and saved somebody's life. On the other side, there are people who can do at least call an ambulance or do something. Forget about say BCLS and things like that, but who are not doing anything.
Yeah.
So the key is for them to understand that somebody is not okay and see he's not responding, and first you go and ask him what's going on.
Yes,
Hello,
yes,
are you
exactly.
okay?
The first thing is, yes, as you said, yes, for a medical person, unresponsive. But for a common man, they can think that he was all right, suddenly he becomes unresponsive.
Correct.
So that is the first thing
Correct.
what they need to
Well
find out,
said.
that there is something wrong is
Correct.
happening. The second thing is, yes, they need to call for the help. So that is always important, because the alone person cannot help. So that means they need to call help, whoever is their surrounding people, so that they can do the next level, that call the emergency, call the ambulance,
Correct.
something they can do.
Correct.
But this person needs to check for that unresponsive person, easy breathing, or is there any gasp of breaths that he's taking. At the same time, you check the carotid pulse also, and at the end of within 5 to 10 seconds, I need to decide he doesn't have a pulse, or a very very feeble pulse in child, or he's not able to breathe, or he's gasping for breath. So that is when I know that yes, his cardia, that means CPR, the cardia is not functioning well, breathing is not happening well, that pulmonary, then I need to start resuscitation. And the first step of next resuscitation is start giving the chest compression for him, so that the cardia which has stopped, and by doing a chest compression, we know that at least 30% of the blood circulation, it starts pumping into various organs.
So what he's trying to say is by doing the chest compression, if you learn it correctly, manually, passively, it is giving 30% extra blood by our compression. At the
Yes.
same time, the pressure you put on the chest wall sometimes triggers the heart to start beating again. You know,
Ye-
that's what we believe, and we have seen it happening enough times. But I want to tell you one story. So this was a story of one of my doctor friends who's in Tumkur, who has a practice there. His sister lives in UK.
Okay.
His parents went to visit sister. Now the family with the sister, parents with the sister, were shopping in a mall in London.
Okay.
In that shop, one of the shops, father had a heart attack and collapsed
Oh.
in the shop.
Okay.
But you know the amazing thing, what will happen here in India? Panic. They don't know what happened. Neer Akbar, Neer Hospital, they do all sorts of things. That shopkeeper was trained CPR guy. He was not a doctor. He's a
Okay.
shopkeeper. Now this guy immediately instituted CPR, and that man came back to India and he lived for another 15 years after that. Can you imagine? If he had collapsed in India, in any mall, including Bangalore, he would have died. Which means the public forget about being trained. They don't even know they can be trained. So we need to start making the public understand. Each of you guys, find out the nearest person like Dr. Basavaraj or his team who does the CPR training for the public. Please learn it. You may be able to save your father's life, mother's life, even your child's life. Because sometimes children put something in the mouth and get choked.
Yes.
And we know this training is just a 2.5 hour training, if I'm not mistaken. 2 to 2.5 hour training on a mannequin. It'll actually tell you how to take care of all of those things. On the other side, we had another neurosurgeon from Chandigarh.
Okay.
Came to Bangalore for a conference,
Mhm.
and he went to KFC for dinner.
Mhm.
And he was eating fish, and the fish bone got stuck in his throat in KFC in Brigade Road.
Oh.
Basuraj, he died in KFC.
Mhm.
Can you imagine? Neurosurgeon. In KFC, he died.
Yeah.
Because the damn bone got stuck in his throat and they couldn't do anything
as
about it.
exactly you mentioned, so it generally when we train the BLS, it includes the cardiopulmonary resuscitation, and we also train about the choking. So choking in a responsive and choking in unresponsive. Regarding that CPR, as I said, the starting the chest compression, which you was trying to
Correct.
mention, that yes, we need to give a good amount of pressure on the chest, so that we call it as around 5 centimeter. It should go down.
Correct.
So that heart should compress.
Correct.
So that the blood should flow.
Correct.
And generally we say 30 compressions followed by 2 breaths has to be given. maybe in the public area, yes, either if it is your own child or if your own family, you can still try giving mouth to mouth breathing. But if you have a device, you can give the breathing through the device. If you have an ambu bag, you can always give the breath to the ambu bag also. So this is what I was telling you about the chest compression followed by the breathing also. And in between, just now what you mentioned about the mall having the next, what things are included is about giving the using the AED also.
Correct. What is an AED?
Yeah. So AED is what we call it as automated electrical defibrillator.
Correct.
So when the heart stops, we do not know why it has stopped.
Correct.
And generally we divide them into two reasons. One is the shockable rhythm, wherein the heart is just fibrillating, or there
Not
is a
beating
pulseless
correctly.
ventricular, not beating appropriately. That is what we call it as a shockable rhythm. So that is a pulseless VT or ventricular fibrillation. The other way around is where the heart has totally stopped, what we call it as asystole.
Okay.
Majority of them could be because of the shockable rhythm also. And if we do not shock early, and just compression and breathing alone may not help.
Correct.
So hence the role of AED, which comes in, which I mentioned you, it is automated. That means when you put the paddle of that AED, automatically it determines whether it is shockable or non-shockable, and it gives us an indication that yes, shock is required, deliver the shock. So hence once you deliver the shock, you can again begin the chest compression. So that is the role of AED, which you mentioned in the ambulance. And just as I was talking to you, in our own apartment, so which consists of around 900 or 1000 families, the lot of discussion was happening because there were sudden deaths of
in the apartment.
Yeah, in the apartment, sudden deaths, maybe a late night party, young
people, huh?
Yeah, young people.
Whoa.
Sudden death. So do not know what was there. And there is a sudden death again even in the near the gym or the clubhouse. So do not know what needs to be done. And many doctors are there.
I know your apartment has a lot of doctors. I personally know at least 5-6 will live there.
Though 30% of the doctors are there, but yes, there was no proper communication to the public that what we can do. So hence I told that yes, let us have a BLS training. And it was a very interesting. Generally, people do not come when we said it is a BLS training. There are a lot of younger, middle, as well as the elderly people were aware.
Those are enthusiastic to learn.
Yes.
I'm glad to hear.
And
just to pause you here, BLS is called Basic Life Support Training. So just expand BLS.
Yeah. So basic life support training, and it is not for only the medical. It is for
the public,
the medical as well as the public also. And there we could take the mannequin and give the proper basic instruction what they need to do about the chest compression as well as the breathing and the use of the AED also. The question also came, one of them said, "Doctor, you said call the emergency." So whom to call? So where to call?
Good question. Yeah. Absolutely. Yeah. Because we don't have, we have that 112 now in, I think.
Yes. If you want to call the government ambulance and the other ambulance also.
Correct.
Then we also gave a number wherein if they call, that the senses from where the call has come. And immediately the ambulance starts rushing there also. So it is a coordinated work also. So we literally checked it. And I said, I want to show it to you. So then I called the so-and-so number, and that guy was already on the way. So I'm coming to your place. Then I had to tell him, no, this is a mock drill, what we are trying to know, what we are trying to say. Then they were okay. So that is what is required, that awareness to the family, to the apartment people, because recently 2-3 deaths, or at least I can say 2 deaths, and maybe a near death, wherein till we reach the hospital, which may take 2 minutes, 3 minutes, 5 minutes, 7 minutes, which is the golden period.
Correct.
And generally, as you know, that all this we are trying to do, because if the heart is not pumping beyond 2 to 3 minutes, that's when you are there.
The brain gets affected, guys. Yeah. Our brain cannot survive without oxygen for more than 5 to 7 minutes. So the problem is, if I revive the heart for 20 minutes, the heart will start beating, the brain is gone.
So I
you have to protect the brain. That's why I'm talking as a neurosurgeon to a critical care of
Exactly. Yeah. So hence, during that period, for next 2 to 3 minutes, where other organs gets affected, mainly the brain, continuing the cardiac function, continuing the breathing is very important. That's what the basic life support is required till you reach the nearest hospital or the ACLS providers.
So you have said a lot of things. So I'm going to break it down and
Yeah.
for the public and get details from you. So this entire thing of what Dr. Basavaraj said till you reach the hospital is called pre-hospital care. Now, pre-hospital care starts at the point of when the problem happened. Then who does what at that determines what the hospital can add value for the patient
Exactly.
to survive or not survive. So guys, one is when you heard him tell about AED. If you go to the Bangalore International Airport, you see AEDs kept in a glass everywhere that you can see. Some of you would have seen, you didn't care because your phone, Facebook is more important than AED. Correct. This is the truth of the process. Nobody cares. Because we have a dialogue in medicine says what the brain does not know, the eyes can't see. Now, even if you know it's AED, you don't know how to use it, there's no point. If I'm not mistaken, in the Western countries, every 1 or 2 kilometers, you need to have an AED in the public place. I have seen AEDs when I walk on the footpath. In the footpath, in building, they have kept it there, like how
Okay.
you keep that thing there.
Mm-hmm.
Very, very important now because they know how to do CPR. They need the AED as an extra thing. So in CPR, second thing he said in CPR is mannequin. So people like Dr. Basraj who have taken it on themselves to train people. How many have you trained so far? Just for my curiosity.
No, I do not know. I mean, it's all started from, as you know, way back in 2006.
Maybe
I mean,
5,000, 10,000,
my name is
20,000?
Basavaraj, so they used to call me as BLS Basavaraj only.
BLS Basuraj. BLS Basuraj. Look at it. So imagine this guy has done so much of social service. I hats off to you, Basuraj. Thanks to you, how many people have saved lives today, you will not even know. But I think that karma and the punya will keep coming to you and your family all the time. So he spoke about a mannequin. So there's a mannequin which pretends to be a human being and it teaches you how to do that. Because all of you must be wondering, how do you teach? Because you can't simulate a heart attack and things. Now, how do you do? And that's when you have a mannequin and they show you how it's to be done. Now, the CPR is done, like he said, if you take the heartbeat, it's beat 70 to 80 times per breath. We breathe about 20 times per minute.
Yes.
So it's a 1:4 ratio. So normally when you have two people doing CPR, remember, if two trained people are there, for every 4 chest compression, 1 breath is given. Is
No,
that the
so
formula?
every 30 compressions,
Huh.
2 breaths are
Every
given
30,
in
2
in
breaths.
the adult. So
Okay.
even if it's 2, I mean, we
Is good
divide them
enough.
into.
That's when you're doing it yourself.
Yes. We divide them into adult, pediatric, and neonates.
Okay.
So in adult, single rescuer as well as 2 rescuer.
Single and 2.
Two
I was talking about 2 rescuers.
Yeah. So even if a single or 2 rescuer is there, we give 30 compressions followed by 2
2
breaths.
breaths. Oh, got it.
Where it comes to the child.
Mm.
So child, it comes single rescuer 30:2, and in a child 2 rescuers it becomes 15:2.
15.
Because in the as the age younger, then the arrest is mainly because of the respiration. So hence it comes that yes, you need to be 15:2.
15:2.
But when it comes to neonates, so there also again, if you are single rescuer, you give 30:2. And when you are 2 rescuers, you give 15 compression followed by 2 breaths is what is recommended.
Got it. Perfect. So I think you have very nicely got into this concept of what is CPR and CPR morphing into where you kept telling about BLS.
Yes.
Now, obviously, BLS incorporates CPR and has other things also apart from just cardiopulmonary resuscitation. So can you tell our audience, what does this basic life support system course? What is the course and how long does it take and what all is taught in that course?
Yeah. So as I said, basic life support course can be done by both medical as well as the non-medical
That means
person.
any human being.
Yes.
Starting with the child who can understand.
And
how is the youngest person who can undergo BLS training?
Maybe if they know that somebody has become unresponsive, maybe what I can say beyond 7th standard or the 8th
even 10 years
standard.
old, because children are very intelligent now.
Yeah.
So suppose the father collapses, grandfather collapses, they're alone at home, it's worth the child doing something and saving the father's life.
Yeah. So one is who can do. So it can anyone who it can happen to their own friends, community and their family also. Hence it should be incorporated into the high school or the college that at least once they should undergo the basic life support course.
Once a year. I would recommend once a year.
Yeah, no, it
ideally.
is. Yeah, it
or
is
once in 2 years. Huh?
Yeah, once in 2 years. What has
years.
been recommended ideally? Yes, once in 2 years is good enough. Or I would say at least once in their lifetime, at least they should do. And obviously, if they are a medical person, once in 2 years. And the duration, yes, generally we say the best course should include at least 5 to 6 hours, but we can train them as minimum as within 2 hours or 2.5 hours on the mannequin. What you suggested, that at least they have done once the chest compression, once giving the breathing,
They
once
should
knowing
get that
the
feel
AED.
of how you keep it and do that. That's very
Exactly,
critical.
exactly.
Yeah, that
So
concept.
hence I would suggest that whether you are a medical, non-medical person, whether you think that it is going to help you or not going to help you, somebody else will do, it's always better that you spend at least 2 or 4 hours in learning the basic life support course, what I would suggest. And this course, yes, we do more often also.
So we need lakhs of Basavarajas, Dr. Basavarajas who are running these courses, because one man can do only so much. So obviously we need organizations driven by the governments. According personally, it should be driven by the governments. It can't be driven by us.
Yeah.
Feel like you said fixed in the curriculum.
They are doing, private hospital also
Yeah,
doing.
but
It's the interest.
that's what. No,
Both.
it should get incorporated. It should
Yes,
go into
yes.
every school, every
Exactly.
college. And I personally think, there are two things you should do, which I've been always wanted to do. One is, do you want to be a lifesaver? Ask yourself this question. If you want to be a lifesaver, helping somebody in the public, like what Dr. Basavaraj did on the Goa beach, and get the thank you call, you will feel very good about yourself that you saved somebody's life. So if you want to do that, I definitely recommend you to learn this course every 1 year. Even come into hospitals and spend time with us, so that you keep your knife sharp, because learning it once, but learning to do it again and again, seeing it, are very different things at the end of it. You just want to do it for personal emergency, then once in 2 years. I will recommend definitely once in 2 years. Otherwise, you'll forget the sequence of
Yes.
how much compression. If you do too much, you'll break the rib. If you do too less, it doesn't work. So you should know exactly how to lock your mouth on top of the mouth. Everything is a science. Everything is what you have to do. Very important to do all of those things. And then how to give the shock, how to use the AEDs and everything else. So that is as for the ABC, cardio, CPR, you said. What else does BLS teach people?
No,
The
BLS.
common things.
No, the BLS, as I said, it is generally resuscitation of the patient without involvement of the drugs and without involvement of the medical person. So that is what is the basic life
That is the
support.
fundamental message.
Yes. So that means without involving the drugs, without involving the
No
medical
IV line,
damage.
no injection,
No,
nothing.
no. Yes.
No tablet, nothing.
No. So that is what is the basic life support which anybody
do.
can do. So in a nutshell, I can say that do not worry that I have a medical knowledge, do not have medical knowledge. If you are trained, at least what I could say, at least for one BLS course, I am sure definitely when the eventuality needs, you will be damn sure that you have done a good job.
They'll be a lifesaver.
Yes.
Good. And the other common things that BLS also teaches just for them is, one is the choking, especially children.
Yeah.
There are different strategies for children and adults, and burns, and sometimes fracture. Can you just give them a brief of what happens in that?
The BLS course also involves what you rightly said about the choking in adults, pediatrics, and neonates. What we decide.
Correct.
But by and large, choking, we divide them whether the patient is responding still. As you said, somebody is eating some chicken and then suddenly he starts choking, or somebody had eating the nuts, instead of going into the mouth, esophagus, it goes to the trachea and then gets stuck.
So esophagus is the food pipe, trachea is the windpipe, and they go one behind the other. So that's the problem for us.
Yeah. So, and then they may say that, yes, I'm having difficulty, and you may see him that he's struggling to breathe.
And they may not be able to speak.
Yes, you may see that they may not be able to breathe, and they may just be sensing. And if you see them, yes, this guy is having a choking. And maybe if you wait for some more time, they will become bluish. So that is when he's still awake. We call it as choking who is responding. So in them, what we suggest is, yes, you go behind the choking person, you bend, make him bend down, make a fist and keep the fist below above the umbilicus and below your sternum.
Between these two places.
Yeah, and make the patient bend down little forward and give him a 5 backward and upward thrust.
Okay.
So 5 thrust, and hope that he may cough out the choke.
So you're pushing it so that thing comes out.
Yes, comes out. But make sure
from behind. You have to be on the. All this is taught in the BLS training.
Yes. So
physically, it's taught to us.
As long as the material comes out, it is fine. If it does not come out, he may become unresponsive. Once he becomes unresponsive, then again the step all remains the same thing, that you assess for the response, check for the breathing pulse, start compression. But only thing is, when you're giving the breathe, again try to open the mouth, see whether you can see the object. If you can see the object, remove it. If you see it is somewhere there and try to poke inside, it may go inside and it can cause more harm. And then just continue giving breaths and chest compression.
Agreed.
So that's what is the choking. We generally divide in the adult pediatric neonates as when he's responding and when he's not responding.
And children normally put them on back on the thigh.
So what I said is about the adults and pediatrics, it remains the same. And for the neonates, yes, you can hold the baby's head, support the baby's
upside
head
down.
Upside the down, face down, and support the baby's head so that the head is downwards, and you give 5 thrusts at the back. 1, 2, 3, 4, 5. And then support with the other hand, turn around, and with the fingers over the chest, you again give 5 compression till the object comes out.
Has to come out. All these, we can't guarantee this is going to come out, but at least you try your best to make sure. Otherwise, 5-10 minutes, they're gone. It's very desperate. In Bangalore traffic, with the ambulance coming, with you carrying, nothing is going to happen. So the next thing, once you have done this, or you could not do it because you did not have BCLS, I'm quite sure many of you must be thinking, if you had known BLS, you could have saved your mother's life, father's life, somewhere. I'm quite sure about that. All of you would have going through that right now in your minds. Next is you call the ambulance. The ambulance comes. In our country, ambulance comes with a driver. There's nobody else in the ambulance. It's like a taxi service. It only has ambulance. So guys, that is of no use for us because it will not have oxygen, it will not have anything else. You have to have an ambulance with a paramedic inside. Is that what you recommend? Is that what's happening right now? Can you elaborate that? What kind of ambulance?
So generally, whenever we transport sicker patients, we call it as basic life support ambulance. Like we call it a BLS ambulance, which...
So every ambulance, you have to now find out whether it's an ambulance, a BLS ambulance. Like we had a stroke ready hospital. Now we are saying it's the ambulance, a BLS ambulance.
And the second one is the ACLS ambulance. ACLS ambulance is, yes, we need a monitor, we need a defibrillator, we need a person who takes care of these things. That's what you are trying to say.
We'll at least go to the BLS ambulance first. Tell us about the BLS ambulance first.
No, it needs maybe an ambulance person and a supporting person.
Correct.
Both of them must be trained with the BLS.
Both of them have to be trained with BLS.
So must be trained with the BLS and the oxygen support is required.
Correct.
So in a given scenario, all the time we may not be able to get the ACLS ambulance with a trained person. But however, whenever we are transporting a sicker patients from one hospital to the another hospital, we say that the ACLS ambulance is what is required.
But so ACLS, we'll come back to the little later, is called Advanced Life Support. Cardiac Life Support System Training. That's usually done to healthcare professionals like us. And ACLS ambulance, in simple public terms, is ICU on wheels.
Yes.
That's what, when you see most of them have written ICU on wheels, that's what it's supposed to be doing.
Yes, exactly.
Got it.
So hence the ambulance should be man-powered by the driver and the support system depending on how sick the patient is there, and it should reach to the nearest hospital. And if you have a facility of if the ACLS provider is there, they can think of intubating, getting an ECG done, and obviously connecting to the next hospital that yes, I got ST elevation MI, I got a stroke, I got an infarct. So those things also can be communicated. What generally is little, I can say slower compared to the other countries. With respect to the population, that how we say that 5 chains of survival, what we call, one is recognizing that
5 chains.
Yes, 5 chains of survival. One is recognizing that patient is unresponsive. Second one is calling for the help, and the third one is medical help, and third one is dispatching the ambulance from the nearest center to them, and again transporting safely the patient from there to the hospital,
nearest hospital,
and then giving them the appropriate medical information to the nearest hospital.
Medical information.
And as soon as be prepared to receive ischemic stroke, be prepared to receive the acute ST elevation MI.
MI is heart attack.
So and hence the team is also prepared immediately what needs to be done. For example, obviously we will come across that acute ischemic stroke. the initial period is the golden period, so that there is another patient who is there already in the MRI chain. So I cannot wait for another half an hour for this patient to wait. So those are the things which we call chains of links of survival, all needs to be met, and all this has to be progressed in our public domain as well. And people are working, but yes, it needs to be made more faster.
No, I think it has to get driven both ways, Basavaraj. This is my personal take on this. On one side, the government or whoever it is has to drive it from the top. But at the bottom, people like you and me, ordinary citizens, should demand it now. They
Yes.
demand it, look for it, because it's all about supply and demand at the end of the day. Because you know that you are aware of this, you look for it, you train it, and self help is the best help. So first you empower yourself, empower your family, you take responsibility. Unfortunately, in a country like ours, health is not worried. Nobody is worried about their health. The government doesn't give budget for health. The families don't buy insurance. They will buy more on jari sari to gold to the mobile phone to the car, but nobody is investing on their health. And that is what I think that fundamentally has to change here. I'm telling you guys, if one thing this video will give you is please take responsibility here for yours and your family's health. And you need to know what all has to be done so that you can get your family in case of an emergency to the right hospital in a way that we can help and save. Because the hospital will have everything, but if you bring the patient in too late, or everything is gone by the time the patient comes, there's very little that we can do to help him get better. But as what Dr. Basavaraj said, ACLS ambulance, BCLS ambulance, it all looks so good. But the question is, there's money involved. Everything needs money. To run the ambulance needs money, to staff it needs money, you have to have people in shift system, they have to be trained.
Yes.
There is a lot of opportunity, let me be honest about that. There is a lot of opportunity. But the question right now, I will ask the public, and I seek answers from it, is who should run this service? Who will fund it? It must be the government. But government is only doing so much. So should private people get involved? I don't know. We don't have the answers. Do you have any answers on this? Or have you thought about it? Has people like me asked you this question?
I do not have. I mean, I have a thoughts and
Please
thoughts.
do share, because you never
thoughts
know
process.
which thought will reach somebody and they take it on, Basavaraj,
As I
because
said,
you have really
as I said,
demonstrated.
maybe the BLS should be made as a part of education program starting from their high school and college.
Which I agree with you.
College level.
I agree with you.
And forget about the high school, college. Even it is not there as a part of curriculum, even for the medical degree.
What are
Not
you
for
saying?
The BDS degree. Like when I did my MBBS, I have not done my
I agree.
BLS.
We also did. We learned it on the job somewhere. Yes.
I did a master of, MD medicine from one of the best college. Yes, I did not do a
My
BLS.
goodness.
Did not do a BLS.
I agree. I'm
so I
saying,
was-
my
I was
goodness,
not
I
aware.
agree.
Huh.
I did my ACLS for the first time after I became a neurosurgeon.
Yes, I did my ACLS once I joined my critical care,
Yeah,
and the
same
whole
way.
lot of things changed after as a medical students in approach of the sicker patients. So that's why it has to be made as a mandatory, at least for MBBS and all the specialty of the medical field.
All
and then
medical and paramedical, including
Yes.
nursing,
Yeah.
dental, therapy,
they
therapists,
should
everything.
not be given a pass certificate without undergoing the BLS certificate. What I could say.
It's mandatory.
Yes.
And maybe they should have had it every year.
Yes.
And so that they have these skills available, because they're
Yes.
a lifesaver. So you should know how to save lives. What is more noble than that, to save lives?
Yes.
Correct? No, nothing more than that.
And then obviously what we are talking about, the public and the common people. So there also the public as well as we as a medical person should interact and train as many numbers as possible, what I could suggest.
And like how you people show off with your new phone, with your new watch, with your new, what is that, this one? Please show off your certificate.
Yes.
I'm a lifesaver. Are you one? And what is stopping you? Think about it, guys. Make it a fashion. Make it a fashion to know CPR.
Yeah,
Make
agree.
it-
I think this,
yeah.
as you said, the make is a fashion
Yeah.
logo will help them.
Yes.
Yes, I have done. Have you done it?
Yes. You can even put up a badge. I'm a lifesaver. Are you?
Yes.
And then, like how, we have a sticker on a car which says doctor, so people can stop us. People find and say, any lifesaver here. It happened to me in the flight. Thanks to bring that up. I was traveling from US to Bangalore in Air France about 6 months ago.
Okay.
And we were on the leg from, where were we traveling from? From Chicago to Paris.
Okay.
And diagonally opposite in front of me was an elderly man.
Mhm.
Wife and husband were sitting across the aisle.
Mhm.
And Then I saw he called the air attender, and they kept talking, went back and forth. And then he kept saying something, and then they looked flustered. Then I tapped that fellow and asked him, what's going on? I realized there was something going on.
Okay.
He said he's having some breathing difficulty. We don't know what to do. I said, I'm a neurosurgeon. Can I help? So he was so happy. Because then I said, I went in, I took a quick history. He's an elderly man who's on atrial fibrillation. He was on, cardiac supports. He was already on blood
Medications,
thinners.
yes.
He was certain something. I realized his heart rate was a little down. His saturation a little down. Put him on the oxygen, took him to take deep breaths. I did certain maneuvers. And then their question was to me, we were on top of the Atlantic Ocean when this was happening. We were crossing the ocean. They said, should we deviate?
Okay.
Because if you say that we can't manage, then we have to take a deviation and go to the nearest land, and that's 1.5 hours away. Because they were flying there. Then I said, give me 2 minutes. Then I assessed him, I checked it, I looked at what it is. I said, no, we can manage him, let's go to Paris.
Oh.
I took a decision, and everybody backed on my decision. If that fellow died, I would have been in soup. But he was fine by the time he reached Paris.
Okay.
And they were so happy.
Yeah, so recognizing that also is very important.
So,
you cannot just panic, say that, no, get down.
Of course. So I had to take so many decisions. And then, everything, they just looked at me. After something, they saw I was in control. Everybody, just listened to what I was saying. And, an Indian trying to do something, for a Caucasian, something going on, they have their own scale. But Indian doctors respected everywhere. Let me be honest about that.
Okay.
And they were so happy. You know what the fringe benefit of this I got? I got 55,000 miles bonus. So I'm trying to use it now. So guys, you never know, you can get some bonus miles like this to use it sometime in your travel.
And on the other hand, I can give another example.
Sure.
Another example is where, in the ICU, where a young lady had an arrest, and we started doing a chest compression. It's a hospital environment. So generally, at the end of 10 minutes, 15 minutes, 20 minutes, if the rhythm doesn't come back, we also become restless and panic what to do. But since this lady was a young lady, whom we felt that yes, there is a sudden arrest and the salvageable, and we continued CPR almost for 60 minutes, more than 60 minutes, for 1 hour, continuous chest compression, breathing and all. And yes, finally she got her rhythm back. And after 4 or 5 days, she walked out of the hospital.
Are you serious?
Yes. So generally, whenever we do BLS courses, they ask us, when do you stop CPR?
That's right.
So we generally say, as long as the shockable rhythm is there, you continue giving n number of shocks. But it all depends on which patients you are trying to resuscitate. On the other hand, there is somebody who is 90 or 94-year-old, already in and out of the hospital. He himself is waiting that I should not be going through. In them, we also do take that it should not cause trouble to him also. So hence, we need to decide for whom and how long we need to continue the CPR.
But Basavaraj, I'll tell you one very different thing. That girl you said, the 60 minutes, I think it is. I am honest. Because everybody with 60 minutes of CPR, don't do equally well. So I'm telling you guys, both of us.
No, I totally agree with you. But let us do our part.
No, I agree.
I agree. Then we leave it to.
I agree. I'm not saying no. All I'm saying is, what I'm trying to tell the public is, everybody with 60 minutes CPR may not do as well. So
yes.
Because they should not say you do 60 minutes and because I heard Dr. Basavaraj and Dr. Sharan talking on the program, and after 60 minutes, why didn't my patient walk out? And you can't hold people to account for this, guys. Because please remember one thing. The one thing we as doctors understand is 1 + 1 is not 2 in medicine.
Yeah, I totally agree.
Every patient is different. Every body is different. Every situation is different. And sometimes we feel he will make it. He doesn't make it. Sometimes we feel he's not going to make it. They walk out of hospital. That is what is the strange. That's what I realized, Basavaraj. There's always a power beyond us that eventually decides for their destination.
Yeah. So for that, I'll give you another example.
Yes,
when we were training, maybe around 60-year-old gentleman who is a chronic alcoholic. He has a chronic liver disease with kidney failure. Like all our batchmates know this patient. He was on 3 inotropic support. That means his blood pressure was low. He was on 3 supports. Three supports. He was on ventilator
in the ICU.
In the ICU. almost 80-90% of the FiO2 what we are giving him. He's not making any urine also. And
that means multi-organ failure.
yes, it's a
or
multi-organ
dysfunction.
failure. Yeah. So that means the liver is involved, kidney is involved, and
Lungs are involved,
lungs are
heart is
involved,
involved.
heart is involved, and there is a financial crisis also what is happening. The family said we do not want to continue the ventilator.
Because they have no money.
Yes, obviously the finance was one of the reason, and he was a chronic
Plus
chronic
alcoholic.
alcoholic.
That's right.
And yes, as long as the family says we do not want the ventilator support, medical persons, we also cannot say that yes. We thought that okay, we will. Without the supports, he may not pull through. He may not survive. But when the support system was removed, he continued to breathe. He started making urine.
Are you serious?
His kidney started getting better, and he started improving. And we have to shift him out of the ICU to the ward. No other consultants were ready to take care of him because it was like too risky. And we continued to take care of him in the ward. And he walked out of the hospital. So when you mention it is the
fate, destiny, God.
We did our job, but we cannot predict what is going to happen, which I also totally agree with you.
Basavaraj, having been in neurocritical care, having been in neurosurgery, that is for 25 years now, I have come to that conclusion. There is a power beyond us that determines some outcomes.
No.
See, what is that power? You can call God, you can call fate, you can call destiny, you can call luck, whatever you call. Please remember that. And we have to do our work eventually.
So that's what, as I said, work is worship. Yeah,
it's fantastic. Work is worship. So you worship. That's why, I'm quite sure Basavaraj also prays every day.
Yes.
I pray before I do every surgery. As I'm scrubbing up for surgery, I'm praying to make sure that every step goes off well. Because that energy, Basavaraj, is where the magic happens at the end of the day. I think what you said was so true. But what has disturbed me right now with what you said is that the BLS and ACLS training is not mandatory in medical schools, at least when you were there. Is it mandatory right now? Is everybody going through it? Is somebody implementing it?
So I don't think it is still a mandatory now.
So what are all these people paying crores of rupees, lakhs of rupees to build colleges?
But in critical care course, yes, it is a mandatory.
What's the point?
Before they take the exams, it is a mandatory that he should show the certificate. Otherwise he will not get into. But it is there in a critical care at least. Regarding anesthesia, I do not know. Obviously, they will be having, but MBBS, medicine, all other specialties, as far as I know till now, it is not mandatory.
So now you understand, guys. This is for everybody. Now, please understand that the healthcare doctor training is not different. Public is not different. We all come from the same society. And this society is not holding people responsible. This is what happened to me when I was in Japan.
Okay.
So when I was in Japan, and wherever I met Japanese, and I told I'm from India, because they think we are all Southeast Asians. The moment I would say I'm from India, they would say two things. Indians, very intelligent. Secondly,
that's
zero.
Nice to hear.
They give zero to the world. I initially said, what is the zero? I thought he was mocking me. Then zero means we gave zero to the world, no?
Okay.
Because India is the one which is mathematics zero.
Okay.
And the value of zero in all calculations, Japanese have understood probably more than anybody else. So they acknowledge. But then I started looking back. If Japanese are having so much of respect for Indians, why are we not having for ourselves? Why are we looking at ourselves as inferior? And why are we not successful? On the other side, David Bashar, they said out of the 25 big companies in US, 20 of them have Indian CEOs and top management, all of those things. That means it's not a universal, not good people. And things like that, and universal, not bad. Then when I started, introspecting deeper, I realized that we are a great race, Basavaraj, historically.
So nice to hear from you because you've been trained.
I'm telling you, the only thing that is stopping Indians from ruling the world and which we can change is our attitude and our tolerance to mediocrity. This chalta hai attitude, hogli bidi. Swalpa adjust madi. How is that possible? Have you heard everybody saying holy body adjust madi, chalta hai? But if I say the same thing as a doctor, it won't work. We will not do that because we want to do our best. That's a very important thing.
Yeah. So, just to give an example, just now, like I said, that I have to finish my morning ward rounds.
Correct.
One of the ISC professor's wife, I've been seeing them since a long time. She had a right side pleural effusion. We have put a pigtail. She's been transferred to the. She's been transferred to the ward. and whole night she was trying to press the calling button to call the nursing staff, and I think it is not working.
Huh.
So as soon as I went in the morning, she allowed me only to speak about that, and I was unable to go medically what needs to be done. But what I also realized is that when I spoke to the nursing staff, they said that yes, the calling bell is not working since last 2-3 days. But immediately the professor, she asked, do not do the checks before the patient gets
Correct.
shifted?
Correct.
So what you
Chalta
mentioned,
attitude.
exactly.
This is chalta attitude.
So we need to include all those as a tick marks.
Yes, you have to be a perfectionist. You have to do your best, and every small person have to do their best. That one nut is not tightened, you have a problem. So that is the key, guys. So as a part of excellence, so one is that. Second is our work ethics.
Yeah.
Somebody has an appointment at 3 o'clock in the afternoon with me. He'll call me at 3:30 and say I'm going to be late. I said, do you even know the time? So if you're meeting outside, you should know how long it's going to take for me to travel there and tell appropriate time. So unless these two changes, and people like us, Basavaraj, we should stop tolerating mediocrity.
It may be other round also, because sometimes the doctors also may be coming late also, which
Yeah, see, I'm not saying intentionally we're
Yeah.
not doing that. All I'm saying is communicate.
Agreed.
So I'm not saying that I'm on time all the time. I'm not saying no to that. But communicate, respect everybody's time.
I agree with
And
you.
also the work ethics of doing everything well. Don't do it adjust muddy self, things like that. And as a part of that, I think we should definitely, second message I want to give on behalf of both of us, every medical college student, we have enough. Bangalore has 14 medical colleges or something. Highest in the world, guys. Highest in the world. For example, world record Guinness Book. And 150, 250 students.
Yeah.
So imagine 14 into 250 is what? It's an unbelievable number. So that many people, and all of them have nursing colleges, all of them have physiotherapy colleges and all other colleges, all of them mandatorily should have been a basic life support system for sure. And the medical student, why not have an advanced life support system? It's not going to harm them at all, because that will also inspire them to do certain other specialties, which can actually make them better lifesavers than what we are. So I think that is one more message that we want to give. I don't think that is negotiable for both of us.
Agree.
I don't think that's negotiable. I don't want to hear the government or the medical college people. There are people paying money. It's not free. There's enough money in those places. It's only the will that is missing. And I want each parent of each person who's studying there going and demanding this from the medical college management. If you go and put pressure, for sure they will do it. And then they'll start showing like how the apartments now promote prestige. They'll say, for example, we have swimming pool, we have 40,000 square feet gym, and they should also say we have ACLS trained, we have AED in the apartment complex. Like that, they should say.
Yes.
The medical college should say we run the ACLS, BCLS courses, all our students are trained. They should wear it on the sleeve. It's like a fashion.
Only thing is, if it is made as a mandatory, which comes as a curriculum,
correct,
then it's a checkpoint. For example, as I said, for our critical care training, since it is made a mandatory, so before applying for the exams, when the teacher has to sign, and they have to upload that it is being done. So unless it is being mandatory, it becomes difficult. So hence, as you said, the people who gives the guidelines for MBBS passing out or the medical passing out, they should do that. And even in the corporate non-medical person also.
The Ministry of Health, the Ministry of Medical Education, IAS officers, all big people. Guys, you have to wake up, smell the coffee. Please do this, because your life may go one day. It can be the minister's life in their own house. Because somebody is CPR trained, they can get saved. Same with the IAS officers. So we are all first human beings. After that, we are whoever we are. It doesn't matter where you are. Not living in a hospital, Second thing, I want to ask you another interesting question that's coming to my mind as you're saying about this lack of training. This lack of training is getting these untrained BLS, ACLS untrained doctors into work. And they are the ones who get into emergencies and some of these places. Can that be one of the reasons for the violence against doctors that are happening to this and that? Do you think that there's a connection? I'm just asking you a question.
So I don't think so. Majority wise, I don't think so. But because once they reach the hospital, yes, there are a trained
Oh, there's a full
AE.
system
There is
there.
a trained AE doctors are
Correct.
there. But yes, we can always think that whether we can do a better in
Better
whatever
job.
in better,
Better job.
whatever we are with our own training.
Got it. Next message, but Dr. Basavaraj is saying is companies like Wipro, Infosys, or what is Microsoft, whoever
Yes.
it is. one campus has 30,000 employees, 40,000 employees. Why not train all of them? As an employee, social obligation. It's a very important thing
Yes.
to do.
Yes. Yes. I totally agree with you.
And we
because
do, for our own employees, we tell them to go and attend your classes only. Many of them have come and attended your classes.
Yeah, I think I do not know some of these corporates whether they got some instruction saying that the fire alarm training has to be done. They do with respect to the fire alarm and fire training and all because it's a mandatory. So similarly, if a BLS is made mandatory for all of these employees who are joins within 3 months, 6 months, 1 year, then yes, things can make difference even in the corporate
I
offices
think
also.
so. Something can happen in the office, but more importantly, all of them have parents at home and people at home that they can,
And
help.
to be frank, they are the better people who can understand the situation, who actually they are ready to get trained.
Correct.
But yes, the facilities needs to be made.
Facility and facilitation.
Yes.
I think that has to happen. I think there's an opportunity, food for thought there. So now we'll move, as we have come very nicely to this. Now the patient has reached the hospital. Sometimes, even in the ward, which is outside the ICU, we sometimes have a patient having a cardiopulmonary problem, suddenly arrest or close to arrest. And we have something called a code blue. There's a concept called code blue in most hospitals now, at least in the NABH hospitals, whatever. So what is code blue? Can you tell our viewers what is code blue?
Yeah. So as you exactly mentioned that it is a part of NABH mandatory that you should have a code blue team in a hospital. And majority hospitals do have. And yes, of course, many of the hospitals may or may not be having this code blue team. So code blue team generally is required for a patient irrespective of wherever he's there in the hospital, either in the ward or in the laboratory or in the cath lab or in anywhere in the hospital or near the hospital. If he becomes unresponsive, as I said, the first step is to find out unresponsive, and the second step, as I said, to call for the help. So what we're trying to do in calling for the help is we generally say, can you call for the code blue?
Announce code blue.
Announce the code blue and get the crash cart.
Correct.
So announce code blue is that particular person who is there, he will go to the nearest telephone booth and he will pick the phone, and it will generally go to a one center point, and he says, in second floor, room number 302, there is a code blue is announced. So that particular person announces all over the hospital through the phone, saying that PA system, saying that in second floor 302 there is a code blue is announced, and the people, there are a code blue team is there. So code blue team consists of the intensivist, anesthetist, cardiologist, emergency person, security supervisor, nursing supervisor, and depending on the hospital, many more to be added also. So all these teams, as soon as we hear and we give the highest importance for the code blue, and then all of us rush to that particular place and spot. And till that time, as I mentioned, the person who has announced will be doing the basic life support, and that's when the advanced cardiac life support sets in. I still remember there's a code blue was announced in one of the hospital in the 9th floor. So the lift was not operating. So along with my consultant, you remember Dr. Jose Chaco, so we have to run to the 9 floors. And I thought that my consultant may not be, he was more active than me. He's my teacher also. And yes, we could attend that. So that means the highest response to be given for the code blue call. So that code blue, nothing but, as I said, the second step when you announce the code blue, the trained ACLS members, including the intensivist, anesthetist, emergency physicians, nursing supervisor, security supervisor, comes in and then start giving the ACLS, that means advanced cardiac life support, apart from what the BLS is happening. This is generally within the hospital setup what happens.
Only. This happens code blue only in a hospital, and don't even think of doing it. We're not going to. This is not a podcast to tell you what we do in ACLS. It's beyond the mandate and scope of this chat. But please remember, this is available. You should know. So you must be wondering how all these list of people, get this gnanodaya. Not at all. What is happening is the code blue teams are formed in advance, consisting all of these people. Each of these members is known that I am a part of this team.
Yes.
And when I'm on duty or on call in the hospital, anywhere in the hospital, code blue is called. Nobody is going to call me personally. Dr. Sharan, please come. Dr. Basavaraj, please come. The moment code blue is called, the relevant people just show up there. It's like automatic, like magic. It has to happen like that. So unless these drills are practiced and trained and done that, nothing happens automatically. Practice makes a man perfect, which is why the constant drills, the constant meetings, the constant situation should happen to make it happen. People like us are constantly in critical care. He's in critical care. I am having my patients in neurocritical care. So like I said, I love neurocritical care. So that's why, we have our knives sharpened all the time on this. So, Basavaraj, now we'll go to your dear topic, which is critical care.
Yeah.
We have spent a lot of time starting from somebody who's not okay outside to hoping that he has brought to you in a salvageable condition. And that pre-hospital care is fundamental for the best outcomes that you can produce as a critical care physician. Now, what got you interested in critical care?
Yeah. So this is the right thing. I mean,
because I know when I was training to be a neurosurgeon, there was no critical care.
Yeah.
Only anesthetist used to come and do basic. That's why I was forced into the ICU, and that's why I became a good neurocritical care guy. It was like a baptism by fire for me at the end of the day, and we were running a 20-bed neurosurgery ICU. It was crazy, but it was great what we learned from there.
Yeah, so I think I did my MBBS from JSS Medical College, and one of the reason that I got into the medicine was through our professor Basavan Gowda sir, so who was inspiration to
Internal
me
medicine,
to get
MD
into
internal
the
medicine.
MD internal medicine from JSS Medical College, and then I got into the MD medicine at one of the best colleges that what you also studied.
Yes, we are alma
Bangalore,
maters.
yeah,
Yes,
so Bangalore Medical College, and I did my MD, and during my MD medicine days, somehow I felt that the critical care helped me. That yes, this is where the acute care is what is required, and maybe
that's where you can have the maximum impact.
Yes. And then yes, to be frank, yes, though I was not supposed to work, yes, I was also attached during that time itself, working in outside the medical college profession in few of the ICUs.
Don't tell anybody, okay?
Few of the ICUs, and then
Everybody
I find that patients are surviving, which I was feeling that patients cannot survive at all. So, and I became little more better than my own colleagues in the critical care. So wherever they say that yes, the critical care is involved, then
that
yes,
is different. One more software app in your brain with others, and the skill.
Yeah. And that helped me that yes, I should become a critical. And to be frank, after my MBBS itself, I was interested. So after my MBBS, I got a good rank, and I know that I will get the one of the good medicine itself.
Correct.
Then I started working in a private hospital. I said I want to work in the ICU. One of the hospital, they said you do not have a critical care experience. Then I said no, I'm ready to work without the pay, and I did work.
Wow,
I did work
that's
for
amazing.
almost 2.5 months, and during this 2.5 months, I gained good knowledge. One of the doctor was there from the US. He was American board in critical care. I got
that's a smart thing. You see, you have to learn all these things. Sometimes don't look at money all the time, because he's got free training from one of the best in the industry. Sometimes even if you pay, you don't get the good people to come and train
I will
you.
tell you the interesting story. At the end of 2.5 years, the hospital owner got a trained doctor, MD medicine guy. Then he said, no, you cannot, I mean, he has come here, so then you cannot work here. So then I did a reverse psychology. No, I have learned all these things. I can do a better job than him. And my consultant, yes, he agreed that yes, I can do. Then I started working there, and then got into the medicine. And this is where I wanted to get my thesis topic also is critical care.
Whoa, yeah, I didn't know that.
Yeah. So which my professor.
So you have that critical care bug in you.
Yeah, my professor, teacher, Professor Puttappa Chandrasekhar, he taught me the medicine. Starting from the basic levels.
So when he says medicine, don't think medicine as Austi.
Yeah.
Now, a lot of this in our medical parlance, when you use medicine, it is internal medicine, which is physician, MD. MD medicine is what we say is he's a he's trained in medicine, means that's what it means.
Yeah. So Professor Puttappa Chandrasekhar, you also may be aware.
Yeah.
So he's one of the best teacher, what I can say, to wood medicine. He taught me about the basics of medicine. That means you always should give respect to the patient, spend time for the symptoms, and examine yourself for the general physical examination, systemic examination, and then get into the investigations, which actually taught me the Bangalore Medical
Step by
College
step.
established. But the things which were missing is that beyond that particular point, the emergency investigations, emergency interventions, emergency what I was aware that were not happening. So that's when I felt that yes, I need to get into the critical care.
That feeling of hopelessness or helplessness, that something more you could do but couldn't do.
And by the time I was little calling myself as yes, I know a little better critical care than the other guys. So that's when I went for. I mean, at that after I passed out my MD medicine, I started working in one of the hospital in Nizamabad, and they
Hyderabad.
Nizamabad, which is in Andhra Pradesh.
That's what. Close to Hyderabad, no?
Close to Hyderabad, Karimnagar and Hyderabad. That's when I learned my Telugu also.
Oh, I didn't know this part of your story.
And they had already, put me as I'm an intensivist there. And there I realized that, yes, when you are alone, it is difficult what you can do. And that's when I came back that I want to become a critical care physician. That's when I realized that I need to know, I need to learn, and I can give the service. Then I came back to Manipal Hospital, Airport Road, and I
again our alma mater.
Yes, where I started
a lot
my
of
critical
common
care
things
course.
that we have. That's why I think we get along very well.
And being a MD medicine guy, so I could organize the things little more faster, disease process, and then which I was not aware about the skills of procedures and all, which I could learn also. Yes, the critical care is giving me the thrill that yes, I'm able to manage the acute patients.
I agree.
And
that thrill, that's the right word you use. Thrill.
Yes.
That nasha is very different. I will vouch for you 100%.
Yes. And over a period of time, I also learned that I cannot save everybody. So hence I've also learned that how to respect the life, how to respect the dharma, how to respect the discharge and request, and how to respect the death and the family also.
You got into a very tricky topic. A topic which is also very close to my heart. So as a neurosurgeon, so all of you know, our global audience, that everybody is promoting organ donation, organ transplant. All of you know that. And everybody is asking everybody, are you an organ donor? Have you signed? Whatever it is. But I want you to know one thing. The organs can only be donated when you're alive, technically. Then how does the only one which can be donated immediately after death is the cornea. Everything else has to be done, when you're alive. So just for you to understand why is a neurosurgeon talking about organ transplant or organ donation, is the key thing that has to be told to the intensivist, valid by somebody like me, is that is the patient brain dead? Only when a patient is brain dead, rest of the organs are working, rest of the organs can be harvested, because except brain, all of the organs can be technically transplanted. So that's why we get involved in that. So that is where what I mean to say is, as a neurosurgeon in acute care practice, head injuries, strokes, so commonly we see, and many of them you see come in brain dead, and it's a constant thing that we are seeing. So that is a different protection. But if the patient is not surviving, then this comes in.
Getting emotional.
Yeah, because though we are doctors, we all get emotional when we see what goes on in the practice of when we see the father, mother standing outside, or the young wife, or the children, everybody hoping that the person survives, but we are not gods at the end of the day, and each person has their own life. So he said, all of us have become doctors, critical care, to save lives, but we can't save lives. Even in the best of ICUs in the world, the mortality is minimum 10%, less than that, 6 to 8%. Sometimes goes up to 50% if it's a very high-risk ICUs and things like that, because of the nature of the medical problem and not because of anything else. So how do you deal with these things, Basavaraj? You're also a human being. I'm also, I know how I deal with that. I want to ask you, How do you deal with this emotion, and how do you sort of
You're talking personally about these
both ways?
sick
You have
patients, yeah.
to patients when see, because
Yeah.
you're in that environment, no,
Yeah.
because there's so much of negative energy. On one side you are positive to save their life, but there's so much hangama going around there.
Yeah.
How do you find
So
balance in your mind?
as I mentioned, that the thrill of working and making him better is always the first response.
Correct.
What do we get? But slowly, if you start recognizing that yes, this patient is not improving, then obviously at that time you need help from your colleagues, which are always there. So generally we get involved with other colleagues, like I will call Dr. Sharan, saying that this is what I'm feeling, that what do you feel?
So you take more opinions to make sure all of us are thinking the same or
Exactly.
agree on the same
So
thing.
exactly.
It's important to work. That's what the next thing he's saying, teamwork.
Yes. Yeah.
So that's the key. So
Yeah.
Basavaraj is saying, I'm not the know-all great. I'm not Tarzan. He's
Yeah.
not beating his chest.
Exactly.
He knows that the more, and I always tell people, the more we know that we don't know. And that's when we get other people, more heads to come in and discuss that.
Yeah. So for example, that's what, when I'm doing my rounds, so I know that this patient is not going to survive. And the students are
Your
there.
gut feeling.
The students are there.
Correct.
So students are there. I know that I can tell straight away, students are saying that, okay, he's not going to survive. But the first thing what I will do is, this is what I'm feeling. Dr. Sharan, what do you feel? What you have spoken to the family? What family feels? And if the neurologist is involved, yes, we speak to the neurologist. If other physicians are involved, we take
Correct.
their help also.
Correct.
Because at the end, it's not that I am thinking that he's not going to survive, which is not an easy decision to say that. Yeah.
Absolutely.
But if
It's not easy at all.
Yeah, if other team doctors also feel that yes, Dr. Basavaraj, what you're feeling is correct, and I may not stop with Sharan, so I may be asking the another doctor also.
Absolutely, we have to. We
Yes.
should. We must.
And then if all the team, as you exactly mentioned, that work is workshop, we continue to work, but teamwork is what is required. And once we all team together decide that yes, this patient may not be improving, and then we rely on our own team of doctors who are working, and we respect the team of doctors which are working around the clock. And you are asking, how do you deal with that? So dealing
Does
with
it impact you personally? That's what I'm trying to say. But when you see death, suffering, the emotion of the family, because we go through all of that every day.
Yeah.
I'll share my thought, but I want to know
yeah,
how
so,
you
so
deal
generally
with that.
I personally divide them, yes, the expected deaths and the unexpected deaths, or the prepared death or the unprepared deaths.
Got
So
it.
prepared death is, yes, we all have gone through and we know that he's not surviving, family has been informed, and the disease process is like that. So there,
already suffering
Yeah.
like a terminal stage of cancer or some other lung problem or something else, and always been suffering for a long time. We know that the
Yeah.
end is
So
inevitable.
there it may not be with respect to the medical problem, but there also the problem comes in dealing with the family.
Correct.
Okay, so
The emotion.
there, the emotional and then attachment, and they will have so many other things also. But yes, it keeps me worrying in unprepared death, sudden deaths. It might happen naturally also. Then for everything you start thinking that whether I could have done better, whether we could have done better. So that is what makes little worry. But yes, of course, as I said, we discuss with our colleagues, team members, so this is how it was situation, this is how it was there, and what else could have been done, and all of, yes, if it could have been done, it is fine. If it not could have been done, what else we can do better. So we discuss with the team, and we'll have a review meetings also. And then yes, it affects maybe for next 6 hours, 12 hours, 24 hours when you go back home also. Maybe you need some time off time also to
course.
think beyond that. And when you start getting into the other patient who is recovering, so obviously you may start forgetting the previous, and then you will start saying that again back to yes, work, and start getting patients who are getting better. But it is not so easy that what I can tell you. Yes, we do go through a lot of emotions also.
I agree. I can imagine, and it can impact your physical health and mental health, and
Yes.
no question about that fact. And I tell all the people who join me in this, I said, guys, unless you learn to firewall yourself or learn to manage this, don't come into this profession, because you can be sometimes gutted. This is a different place to be. Critical care, neurocritical care, the kind of work we do is crazy. Life and death is like this. Before you turn this side, you turn that side. This, they don't give us time to think sometimes. It's so fast.
Yes.
And it's frightening sometimes. And we have all have learned. That's why the more time we spend on the ground, the more time we learn. Sometimes learning is not doing. Sometimes just observing what others do is equally important. In fact, people ask me, I've told, that I used to work 150-hour weeks in neurosurgery training. People say, how are you working 150 hours? So in fact, I just want to make people understand we are a 24/7 job. It's not a day job. So we are doing night duties, So my schedule when I was training as a neurosurgical resident for 5 years training used to start Monday morning 7 o'clock till Tuesday night 9 o'clock. Wednesday morning, Thursday night, Friday morning, Saturday night, Sunday morning, Monday night. It was a ruthless 36-hour alternate day calls. Because there was so much of work going on there. Every person had to be on board.
I
You
think the
cannot.
software industry, this has come off late. Think how many hours one should be working.
That's what.
And when I started calculating along with my daughter, and daughter said, "Papa, you are working more than what the best person has told in the world, because 240 hours per month, exactly what you mentioned, working continuously for 36 hours is more than what is been told you can. This is the maximum what you can do. We are working beyond that also, but
Absolutely.
that fascinates us only because we enjoy what we do. So,
And we have no choice, Basavaraj.
Yeah.
The thing is, like, for example, let us say you are not on call, I am not on call technically. But when we get a call at 2 o'clock in the morning, we have to take the call. And sometimes, there are times that I have called him at 2 o'clock in the morning and said, Basavaraj, what do you think? And we are discussing the case 2 o'clock in the morning. Or he calls me. And then if we decide one of us have to go, one of us show up there. No, it's like that because we feel that we going there or, we have somebody else who can manage it. That's so. So that means even at 2 o'clock in the morning, we have con calls now if required to know what is going on because we want the best for the patient because you said time is life. We can't wait till morning to figure out what is going on.
And exactly, the work-life balance means obviously balancing is having more team members who are of the same,
With the same
passion, capability, because work gets divided. That's when I was initially thinking that I only should do everything, and over a period of time I have changed that. Yes, it is the teamwork, and I should make, as you exactly said, many such members who can do the similar work. Initially, I used to think that I can only do the best, but now I started believing that yes, other people also can do the best and they can do the similar things. But of course, you need to put your own thoughts also. I'm sure that you also are in the same process. That's why you have built so many employees and so many neuro rehab teams also.
I tell my boys the same thing, guys. If everybody comes looking for you, it is good for your ego, bad for your business. That's the truth of the process because that's the reality. So you have to be, and if you look at Indians inherently for a long time, we were good only in individual sports, chess, table tennis, like that. We were not good in team sports because somehow this teamwork didn't exist because if he gets more recognition than me, that whole thing about, the whole game, because we were brought up in this negative mindset that until I screw Basavaraj, I can't grow in this company. I am not taught that you do better than Basavaraj, you'll do better is never taught. Everywhere it's the whole damn thing.
Exactly. Over a period of time, as you was telling, that if other person grows along with that, you are also growing. That's what I learned.
Absolutely. And also, if you get the guy to your level, you are automatically pushed to the next level because you have another 5 people, so many more things to do.
Little ups and downs, screwing out, you mentioned. So those things do happen. That is a part of
life. Sometimes it has to happen to,
for a betterment.
The cut and meet of life. The cut and meet of life.
And you learn from that and then do better.
Yes, absolutely. You have to learn, guys. Every breakdown is where we had a breakthrough of what is going on. And that is what is very important for us to know that we have to do it like this. So I'm glad that, today people search the moment they have a medical problem. They say, who's the best doctor? I want the best neurologist, best neurosurgeon, best intensive care. How do you become best, Basavaraj, according to you? Can you sit at home and become the best of anything? You can't. You have to be on the job, no?
Yes.
You have to keep on. If you want to be a best batsman, you have to keep on batting. You can't look at batting and become the best batsman. So you have to be on the ground. I would tell my junior students, even now, the best times we got trained was, when you're just finishing post-duty and coming off and one good patient comes and you go back and, learn because you have no headache of the duty at that time. You can peacefully see what your senior is doing and actually learn what. Don't you think that has happened to you many times?
Yes, it has happened many times. And then maybe we generally used to say that, okay, if you have got that procedure, you call me, I will come.
Correct.
I need to do upper osteostomy, you call me back. So that's when we started learning also beyond the work timings also.
And and just because you mentioned tracheostomy, When I used to teach tracheostomy,
It's a
for me,
favorite topic for
yes, for
Dr.
me,
Sharan, I know.
for neurosurgeons,
Yeah.
basically. And I used to teach tracheostomy to the juniors between 12 midnight and 3 o'clock in the morning. That's the only time I had. Because every other time, so much was going on for the patients, and ward, and this, and OT, and it was chaos.
And it fascinates me also. Like yesterday, again, I was telling them that one of the patient that Nagin, who underwent the
Coiling of the
coiling,
aneurysm.
and then he's weaning. Then we discussed tracheostomy, and yesterday was doing well. So I actually, in fact, I blocked his tracheostomy tube and then made him to speak, and the family to come in, and they were very happy that he started speaking. So even that field is also one of the interesting point. Like, yes, you are asking a critical care physician and a physician, and then who can understand, who knows what the next person wants.
I think so. I think it can't be. See, what is happening in the West with all these specializations and all these things going on. There's a joke in the US. You have a right nostril doctor and left nostril doctor. Specialty that this fellow
Okay.
doesn't know what's happening yet. This fellow does. It's like we say, what the right hand doesn't know what left hand is doing. And if that happens, there's chaos. And that's why we need what Dr. Basavaraj is saying. We need one leader who holds the story of the patient together. Okay, it's very important, guys, when multiple things are happening to the patient, the family is also confused who's telling them what.
Yes.
So when many consultants tell their perspective, somebody like him or me holds the story together, tells the family this is the whole thing that is happening. This person is saying this person doing. Then they understand that here is one person I can trust that he is taking care of my father or mother or something like that. And I think that's very important.
Yes.
Tell me one day in your life in an ICU. How does that happen? You tell me. Let the viewers know. I can see the glint in your face, because you see, if I tell him physician, he may not light up so much. The moment is a critical care, the kind of stress, guys, you should come into the ICU to see us working. It is crazy, but it keeps you so sharp, so on your feet, analytical thinking. I'm going to come to analytical thinking a little later. But tell me, what is your life in an ICU on an
like
average
this.
day?
Okay, yeah, the very small period what I get to spend my daughter is dropping her from my home to the school. So maybe 5 or 7 minutes or 10 minutes, which I generally speak, and I do not take any calls. And after that, yes, I get into the ICU. So ICU, like generally, even if somebody calls also, they themselves, my friends, as soon as they hear the noise, they will say, doctor, ನಾನು ಆಮೇಲೆ phone ಮಾಡ್ತೀನಿ.
Correct.
So that is
That's
when
advantage of being nice. You can hear the beeps. Same thing in the OT.
Yeah. So that's when your total, what I can say, the gear of working more faster, more quicker, taking actions, and analyzing. And once you analyze, you need to.
I want to just stop here. You heard both of us saying, we take the call and people say, oh, you're in the ICU, and you must be thinking why they should be taking calls when they're in the OT and ICU. Because please understand, it may be somebody like you trying to reach out to us that I have an emergency. So we don't know, because our numbers today in India, unlike the West, our numbers are given to everybody. A lot of unknown people call us seeking our help. So many times you have to call, and then we say, is it not urgent? Then you call me later. So that we have to do that. It's a part of our profession.
So close friends of mine, they joke because they know that no, I will not receive, but I will call whenever I'm free. So ಡಾಕ್ಟ್ರೆ, ಇವತ್ತು ರಾತ್ರಿ ನಿಮಗೆ ಮಾತಾಡಿಸ್ಬೇಕಾಗಿತ್ತು, ಅದಕ್ಕೆ ಬೆಳಗ್ಗೆ ಒಂದು ಮಿಸ್ಡ್ ಕಾಲ್ ಕೊಟ್ಬಿಟ್ಟಿರ್ತೀನಿ, ನೀವು ಫ್ರೀ ಆದಾಗ ನಂಗೆ ಫೋನ್ ಮಾಡಿ, ಆವಾಗ ನಂಗೆ ಏನಾದರೂ ಕೆಲಸ ಇದ್ರೆ ನಾನು ಹೇಳ್ತೀನಿ ನಿಮಗೆ ಅಂತ. So that is what. Yes, the day begins with, yes, you take the handover of the patients. Around at least 10 or 15 patients are there under you. And then the registrars are there, who again gives you the handover in the night, what happens. And you spend enough good number of time, which I said that I believe in clinical medicine, then into the critical care. So you go through the history.
Every patient tells you a story.
Yes. Yeah. You yourself,
not verbally, but there's a story going on.
Go through the history, that what has happened outside here, then examination, go through the files, you do your self examination, and then come to a conclusion. And whatever I feel that yes, I need to speak to the specialist and then ask them what it is, and we do the rounds. At the end of the one rounds, I feel giving medical treatment is 50% of an intensivist job. So another 50% is non-medical things.
What is that?
Yeah. So non-medical things is out of which I can say maybe spending 20 or 30% of the time with the patient's family. Another 10 to 15% time is to improve your own system, and then obviously take the management also into the loop, saying that yes, I want this, I want this, I want to improve this.
How to improve quality of outcomes.
Yes. So that's what I would say even to our students, that 50% is what you change the medicines at the bedside. Another 50% is how you are non-medically good with your own
Very
colleagues, with
interesting.
your own nursing staff, with your own in charges, with your own colleagues, consultants, and to the management. Yes, the
You're
teamwork.
constantly
Yes.
saying team.
Yeah.
He's talking we, not I. He's
Yeah.
not saying that I am like me, Tarzan. He's not saying that at the end of the day.
Yeah. So that's what. Yes, I always believe that yes, we together can make the difference.
I agree.
And we have
No
shown
question.
and we have shown the difference as well.
Which is why it's been, 15, 20 years we are working together and enjoying each other's company because
exactly.
of that.
And then the family counseling also starts, and then sometimes our decision also changes as per the family's wishes and all.
That's right.
And generally the people also, I mean, like exactly the question what you asked is that how do you deal with the family? Do you get stress? The one thing I generally believe myself as well as teach my students also, always believe that what patient family is telling is the truth, and
Correct.
they're having
I
a
agree.
concern.
I agree.
If I believe that yes, they're talking correctly, they're talking truth, then only I can solve the knowledge. If
True.
you start thinking that no, they're making story, they're doing this, they're trying to check me and all, they may be checking me, but yes, so if I believe that my stress little comes down because they're talking truth, you get involved into that, you try to solve their problems. They may be talking medical problem, they may be talking non-medical problem. Non-medical
Because
problem.
they don't, they are trapped.
Yes.
Because see, emergency yargo keko marala, as we say. It comes to anybody at any point of time. They were running their life, that itself they were struggling, and suddenly this happens, their whole life is derailed. And they are struggling to know what the hell is going on, especially Basavaraj, when the wife is uneducated, not working, and she doesn't know what that husband was doing, and he's fixed. She's in a mess.
Yes.
Because she doesn't know anything that is going on.
Yeah. So that is where the family counseling also happens.
Yes.
And after that, again, we debrief that what we have counseled to our doctors, and then we also speak to the consultant, take their advice, and then debrief to the next level who is going to take care. And yes, there is some time which is spent in teaching also. That is also helps. I mean,
Yeah, I know
it motivates
you
me.
love teaching.
It motivates me. The teaching
Motivates you.
Yes, it motivates me.
That's why I want to make sure I heard it right.
Yeah, it
what do you mean motivates you?
Because I teach them. To teach that, it motivates me to that I should be knowing. I should be
makes
reading.
you a better knowledge. Your knowledge base.
They ask a certain question which I may not be having the answer, or even the students are allowed to ask questions and argue against my views. So you go back, read, and then come back and next day say, boss, you are right, I was wrong, but this is what it shows. The next time again, yes,
that
we
shows,
can say.
Basavaraj, what I'm trying, Dr. Basavaraj is saying very casually, matter of fact, is not easy. Please understand, here is a super qualified guy, super successful guy who's on the top of his game, and he is now telling us that he may not know a lot of things, and if he doesn't know, he has the the honesty to say, I do not know, I will read and come the next day. And if there's a small chota student in his system who can challenge him and he can be right, that means I also tell my people the same thing.
Yes.
None of us own the knowledge.
Yes.
And you should be the student of the subject all your life.
Yeah, I agree.
The day you stop learning, you die. Not physically, but mentally. The third thing is learn to say, I do not know. And people like us, the more we know that we don't know.
Exactly.
And that's what excites us every day, because he tells me something in the IC one day. I say, Basavaraj, I learned something new today. I tell you this all the time. And he says the same thing. Yes, because we are constantly learning of each other. And that's why I love to wait to chat with him, because maybe there's something I will learn today that I can use, put it into my toolkit, that it will help some other patient in some other place.
And maybe at the end of these things, maybe I get 2 minutes or 5 minutes of lunch, which I will have, which my wife always scolds me, saying that you should have at least half an hour of time that you should
half
spend.
An hour is too much.
I should spend
Mine
time
is less
in
than
lunching
that.
and all.
I can imagine.
So we finish, and during that time also we do calls and we do answer, and then and it is the enjoyment that what I go through, and then speaking to the family, speaking to the staff, speaking to the consultants. And then as soon as you said exactly that, no, I do not know, I want to learn, I please tell me, and I can tell you openly, I did not know this. So that makes him also happy, that makes me also happy. Correct. And next day we are happy to learn from each other.
Yes. and he will want to become part of the team, because
Yes.
very rarely
Yeah.
there are leaders who are willing to accept this.
Yeah.
And the true leader is somebody who's willing to say that I do not know, and there are people smarter than me. In fact, Henry Ford, in one of his books, Henry Ford, no, that Ford Motors, he wrote in one of his books,
Okay.
if you are the smartest person in your team is designed for failure.
Okay.
Because you are the only driver. Everybody
Okay.
else is passenger. If the driver stops, the train is there only. It's not going to go anywhere. So you have to make more drivers, because then you can become passenger and relax for some time. So the power is in that.
Yes.
But people keep all the secrets. They
No,
don't
I'm
teach.
correct.
No, I don't want to teach. Hey, if he becomes better than me.
Yeah.
And that is the wrong way to doing it, guys. If you want to, I tell everybody, I teach because I am lazy. Because I want others to do some of my work so I can take rest, charge my batteries, and do also other things that they cannot do. And I think that's where every team member punches above their weight. I'm telling you, the entire world will transform.
So exactly. So apart from believing yourself, yes, you need to believe what you're doing is correct, what you're doing is good, and yes, you believe yourself, and then yes, but take the team along and take their opinions also, and see that everybody is happy. And yes, some may be in the lower, some may be in the higher, but at the end, we are all equal as far as the patient is
Yeah,
concerned.
every person contributes to
Yes.
the larger picture of what happens. Everybody can't be the superstar.
Yeah.
In a movie, there's only one hero, one heroine. But every actor, every person in that whole team, contributes to making that a successful,
Yes.
movie or whatever you call it. So, but you didn't give me details of what happened. You said generally what happens in the ICU.
Mhm.
But tell us about when a patient crashes, the intubation, the ventilation, this, that. Can you give us some story of one patient? Suddenly it happened, how you were doing around, something happened, you jumped in, rolled up your sleeve and started doing stuff.
Yeah, so maybe it happens every day for us. Every
Which I
day, so
understand.
like
If it doesn't happen, I was wondering, are you in the ICU at all?
it happens every day. So that yes, we believe that somebody is doing well and suddenly goes down. Just now, we have spoken to the family that he's been improving. In the morning, Dr. Sharan has come saying that no, he's getting better, but suddenly he becomes sick.
Had an epileptic fit or something happened.
Yes, and then obviously you need to attend the sicker patient. That's what generally we divide, that who is the sickest as soon as I enter, and we do the rounds for the sickest patients.
So you triage, you prioritize, and then it's not like bed number 1, bed number 2, bed number 3. You don't go like that.
No. Who is the sickest and who
Correct.
is the new admission guy? So based on that, because and immediately it's not that we wait for the family counseling to happen after 2 hours. If I need to speak to them and take some decisions, we call the family immediately and then take the decision what needs to be done then and there only. But on the other way, that patient is stable, but the family are more concerned outside. So we also address them also.
Communication, yes.
So we also address them. You please,
True.
Bappa, you wanted to see the family. Yes, you please, because he also is having a lot of anxiety. Though I feel that patient is stable.
Correct.
Yeah. So as you mentioned that yes, suddenly
the ICU is a phobia for a lot of people. Let's accept that.
Yes.
The moment ICU means there's something wrong with me.
Yeah.
Because normal guy, first of all, going to hospital itself, people are psyched up. On top of that, you put him in ICU, they are completely, especially if they are conscious.
Yeah. So suddenly, if the patient becomes unresponsive, that usual our story goes that yes, you immediately see that whether it requires a airway. So you
same ABC, same CPR, same ACLS, same BCLS.
Yeah.
The whole story. That's why I started from there, because you understand the story is the same, expertise is different, technology as availability is different, because of which outcomes are different.
Yeah. For example, you also know that young guy who was from Andhra Pradesh who had met with an accident, who had come to the ER. His GCS score was 5 or 15. He was just moving, and he had a brainstem bleed. And nobody, no family members were aware. And next day morning when we did rounds, then he was already brainstem reflexes were absent. Only the close friends were there, but wife was not aware. Then yes, so we need to speak to them also. We'll make the wife understand that what is happening, show them what is happening, and then discuss with other family members. And then apart from saving the life, we have to move on to what we call a comfort care and
palliative
care, and then the end of the life, what we need to do. So generally our routine goes with all these things. If we have a good stable day like what you mentioned, then we are happy on that day. But most of our days will have one or the other sicker patients going down.
There'll be a lot of chaos.
Yeah.
So Basavaraj, that comes automatically to the next question for me. When so much is being thrown at you and not in an organized way. And I've not seen you stressed, hassled, with all your hair standing like this, in the ICU when I've interacted so many times. And I can see you're dealing with things. Is not, just looking, and you're a hands-on guy, which also I know you're not, just a manager. How has you're training yourself to do analytical thinking? How has that helped you to really, take decisions like this, sharp, fast, yet accurate?
Yeah. So, I
Can you
mean,
give our viewers what is the skill of being fast, accurate? What is this magic mantra that you have?
yeah, maybe even I have gone through the various phases of life, saying that yes, you keep shouting and doing everything and make it more chaos. Those periods are also that I have gone through.
Shout and do more chaos.
Yeah.
Not the shouting doesn't
Exactly.
reduce the chaos.
Yes, exactly. So
I agree with
through that,
Basavaraj.
over a period of time, as I exactly mentioned about the training your team, and then team members are there to take, and you are there as a leader to decide between the patient decisions and the works and procedures that needs to be done by your own team members, and you be there as a leader to speak to the consultant as well as the family. It's not that we do not go through the stress. So stress happens at the management of the patient, procedures, and what needs to be done, as well as speaking to the family also. The question what you asked is how do you deal with that? Yes.
Now, how do you
Yeah,
something happens to
yeah.
the patient?
Yeah.
Something has happened. What that something has happened is the key right now.
Yeah.
Based on what the something you diagnose, because you don't have time to do A, B, C, D, big thing.
So
Quickly you have to take action.
So generally we believe on the teamwork, saying that I know that my team members, they can do this job is a better. So we allot that, yes, you take care of the airway, you intubate, start CPR, I'll speak to the family, I'll speak to the consultant, I will arrange for the CT MRI machine, and hence you be there as a team leader and then as well as speak. And yes, you end up with a situation where you do not know. Sometimes you need to discuss, you speak to the other colleagues also, give a quick calls to them, and then yes, at the end I am there in the ICU, I need to decide. It's not that other people are taking, and yes, take their inputs and then make a decision, and then yes, go through that flow, because you already discussed with the team members, you know that we are all together and we're all able to take care. So believing in the team, believing in your own colleagues, believing in your own hospital management, saying that they are there majority of the times, but sometimes it may not happen also. But there are certain situations where there are some differences of opinion, which generally may take you a stall, which hurt you, but to come out of that, it will take some time also.
So, what he's trying to say, and which I am trying to pull out of his brain, as a brain surgeon, is what is that magic thing? So, see, unless people like him and me have the experience from the ground, this decision making cannot happen fast. Eventually, you have to be on the ground,
Yes.
dirty your hands enough, and constantly dirtying your hands. You can't say that I did it 5 years ago. Nothing. Do you agree?
Yes.
That I think that's why we are, we can do what we do, because every single day we are on the ground, touching patients, doing these things, doing the procedures, doing the surgeries. So we know exactly what needs to be done. And that, I think, is another message that we want to give. Don't become a manager, be also a doer at the end of the day. Managing
Yes.
has only so much of limitation, because somebody can't do, you should be able to go and do it.
Yes.
Eventually you can't. Now if the person can't do, then you also can't do, then somebody else has
That's
to
the
do.
problem.
Who's going? So the buck stops with us. The action buck stops with us. At the end of the day, they will look at us, sir, I can't do it. Then or he says, you can't do, let me do, and we jump in very quickly. And I think that's a very a powerful place to be. I think fantastic. So now you saw that Basaraj is, saving people's lives. He can't save everybody's life. It's a process that happens. And we're not getting into the medical details of how many reports he has to see, how many of those reports he has to analyze, how much of that past history of the patient he has to remember, and to go back and take a cumulative decision making of what is happening, what had worked in the past, what didn't work in the past, and then check this, check that, do this blood test, this x-ray, this, that, based on his age, whether he has sugar, he has BP, he has this, he has that. There's so much of data points that you're dealing with, and then after all of that, you have to come up with a coherent solution,
Yes.
which you believe with your wisdom and your training and everything else should be the best possible way out
Exactly.
to get the guy out of this mess.
Yes.
And in spite of doing all of that, what I will tell on his behalf and all on our doctor's behalf is, we can give the treatment. The response to the treatment is not in our hands. If the body has given up for different reasons, it does not respond, then there's precious little that we can do to get it better. And that sometimes we will never know what is happening in that process. So before we move out to your physician role, you have anything else to say?
Yeah, maybe in the critical care, I think, as you said, that yes, we need to know that whom we can save lives. At the end, there is certain period that where we cannot save life also. That's where it comes as the comfort care or the withdrawal of the life
Thank you.
support.
Yeah,
Withdrawal
I
of the life
missed that.
support. I mean, it may not be the perfect thing that what each person does, but it all depends on each individual patient and their family members and their colleagues also. So at the end, we need to respect the patient and family, give a
And
dignity to
yeah,
the
yeah.
family and dignity to the
Dignity in
end of
death is what
life
we
care
say.
and
Yes.
dignity for the death also. So generally we say that, I mean, I say that yes, if there is a patient who is going on request, who is going a dama, who is going death, should be taken the highest priority. Otherwise they believe that no, he's not going to survive. Family do not know, they're just making the noise. But I believe that no, you call them, you speak to them, ask them where are they, how they are taking,
Why are
and
they going where they're
why are they
going?
going, and what do you do, what is your
True.
plan after going home. And at least that makes them comfortable. That means you are a part of their thinking process, what is happening. They, at the end, they may ask, no, we want an ambulance driver, because they may be struggling 10 members to call, where actually it is there with you. So they may be thinking that what needs to be done after going home. So little medical inputs, as a, as I said, exactly what patient party is asking you, you know that he's
In a
asking the right
layman's
question
language,
in a layman's language. Yes. And that helps to deal with this end of life care as well as the death also. And yes, we need to give equal importance for these aspects also, apart from managing the acute critical care also. So we need to know where we can put our energy in, but we need to also know that wherein we have to start thinking that whether we can stop doing everything.
Well,
Otherwise it'll waste the patient's I mean the family's emotion, family's financial burden,
yeah,
and
especially
they
in country
continue to
like
suffer.
ours where
Yes,
a
yes.
lot of people pay out of their pocket,
and
it
and
becomes
and
very.
and to be frank, it is very difficult to say who is not going to improve. For
I
example,
agree. I agree.
especially with you being as a neurosurgeon and neurorehabilitation, very many times we have thought that no, he's not going to improve. There are many cases
Yes, I
which,
pushed you. I
yeah,
said
many
no, no, no.
cases, yeah. Young patient who was there on the ventilator, he's having seizuring continuous. I told you, Sharan, I think we need to stop. You said no, let us do. And then he got out of the ventilator, he got out of the ICU, and you said you always send it to us to ICU to see that okay,
Correct. The
Basavaraj, this
outcome.
patient has improved
Correct.
outcome.
Correct.
So it is a very tricky
In
situation at
fact, you
that point
remember
of time
Naran
also.
Swami also, that
Yeah.
cerebral stroke that we had. You remember he also
Yes,
troubled
yes.
us so much,
Yeah.
and you had said the same thing, and we were talking between each other. Is it what's going
And
on?
only solace we feel that yes, they come back and they are doing well.
Correct.
So that makes you happy than their family and their family community
Absolutely.
taking.
Absolutely.
So yeah,
I agree. So all this while, I've not yet spoken to Basuraj about neurocritical care.
yes.
That's my poster. So critical care we understand. So what is neurocritical? What is that extra dimension and extra stress that neurocritical care adds to you as a person?
Yeah, so I do not say it as a stress, because we both keep enjoying. So neurocritical care to the common man, I can say something what we do, acute critical care of the brain and the spinal cord, both neurosurgery as well as the neurology that gets involved. So maybe we may be dealing with like an acute ischemic stroke, or brainstem, I mean the cerebellar bleed, or a
Brain
road traffic,
hemorrhage,
brain hemorrhage,
or
road traffic accident,
head injury.
head injury. So those are the things which needs to be done. And there are certain situations where we call it as a window period or the golden hours, where we need to act faster, and this education needs to be there even to the patient's family, as well as the public, as well as the medical field also. And there, the, as you always say, your general quote, the time is the brain.
Time is brain.
And
Absolutely.
every second the neurons keeps drying. So we need to
Dying, yeah.
say that, and I totally agree with that. So in these neurocritical care, so we need to spend we need to analyze, assess, and act quicker. Critical care part, that means we need to secure their airway to maintain their oxygen, prevent their seizures, put an arterial line, and maintain their blood pressure, and then if there is an emergency, speak to the team and then take him down for a CT scan and MRI and decide what needs to be done on emergency basis. Neurology, yes, there is a acute neurocritical care neurology also, which includes like Guillain-Barré syndrome, where you need to manage patient needs to be on ventilator, myasthenia patients, and acute spinal stroke patients, paralysis patients. All these things, patients we do manage. And good thing of this is when you take care of them in an acute situations, both patient and family, and after that they give us a good time that we know what process is happening.
Correct.
And yes, there is a very good recovery, especially you being as a neurosurgeon as well as neuro rehabilitation. So, and I have seen many patients when we are managed acutely, both patient and the family, over a period of time, and they have got a very good recovery. What we have
Outcome.
seen, that is a good thing. Yes, I also believe that yes, it's a natural process that there is a recovery,
The transition from the
transition
ICU
phase.
to the ward.
And yes, but there is an involvement of the neurosurgeon, physicians also, whenever ups and downs, that we know that what it is happening, and then we need to treat, and that helps for the natural recovery process.
Yeah, so, what Basraj is trying to say is, see, we have a concept that we have patented called C2C, which is for the brain injury patients from coma all the way putting him back into the community. Community means wherever he, family, work, whatever. It's a very long journey. Now, in this journey, the journey starts in the ICU on ventilator and then goes all the way till he's able to climb into a car and get into the mall and do shopping and everything else and get back to work. Now, that's where our, this partnership has worked very well, because many times in this course of this journey, they have critical care challenges that, I need somebody like him to pick his brain on. So many physicians are not in critical care. Many critical care are not in physician's job. And when we have a patient lying in bed for 2 months, 3 months, 6 months, their challenges are very different from the acute care when patient comes in from the community, in a sick situation. So here is one gentleman who's been so kind that he has adapted to that and really helped us to deal with that. So tell me, Basraj, when you see our patients, what got you interested in this, and how has this actually molded you in a way that you have?
Yeah, to be frank, yes, I did. I mean, I do, and I'm enjoying taking care of the neurocritical care patients over a period of time. Because, as I said, acute critical care is our primary goal, that we do take care. And once acute critical care goes in, then the process of neuro rehabilitation also sets in. Neuro rehabilitation, apart from the disease process, apart from rehabilitation, that what you do, we need to understand the patient disease process, what is going on also. And me being a physician, because I do see patients from outpatient basis, the patients in the ward, patients in the ICU, and a follow up. So that helps me that how
You get a comprehensive view, journey.
comprehensive view, because at the end the patient party family may say that yes, about the financial situation. So patient party say that how long it may take. So those are the non-medical things we need to be aware also. The patient say that I'm staying far away, what needs to be done. So that will help you. I cannot say no, it is not my part of care. So I do my own analysis, decision, treatment for the medical, neurocritical care, and maybe a little bit of other surrounding
Social
departments. For
support.
example, somebody who's having a bleed, so I will think that no, this is a stress bleeding, there is no need to involve right now the medical gastroenterologist. The next day if it going down, then I can decide that it has to go down.
Correct.
Rather than answering then and there itself. Patient is not moving the limbs. Since I'm a physician and a critical care intensivist, I know this is because of the critical illness neuropathy, and at least to tell the family that yes, he has got this and it will take a longer period. Nephrology department. So since I'm a physician, it is easy for me to grasp rheumatology, nephrology, gastroenterology, neurology, a bit of it, and as well as take care of, be in touch with the specialist and the super specialist also. And when it is required, you can take their help. When it is not required, yes, I still say that yes, I can manage these patients. Maybe a physician knowledge which is being trained and taught helps me to take better care of the neurocritical care as well as the patients who are there in the ward. And as I said, the medicine is 50%. Another 50%, I always believe that yes, I need to own the patient.
Correct.
It is that I am taking
said.
care, even if it is another department question, but at least I need to reach to him. If patient has got a tracheostomy bleed, I will manage, but I need to call him and inform. Otherwise, unless I call him, he will not be knowing. And I need to tell him how urgent it is. So sometimes I say, no, you can come and see tomorrow. But I say, no, I want you to come and see in the today afternoon.
Correct.
So that helps me that yes, this is the emergency situation, and this is not an emergency situation.
You can triage the situation also
situation,
and decide.
And that helps me. The other consultants also feel happy that yes, when I give a call emergency, they will come. When it is not there, yes, he will manage till then.
I agree.
And the non-medical things is about speaking to the family, because when I speak to the family, I feel, I speak to them thinking of the entire patient, not about my department.
Correct.
So as a whole together, it's not neurologist job or a neurosurgeon job. Is so that's what I feel, that it makes me a better person to take care of the patient, as well as to speak to the family and take help from the others as well.
And that's where, sometimes if he's stuck somewhere, I communicate on both our behalf. And if I'm stuck somewhere, he communicates on both our behalf. And we tell them that I've spoken to Basavaraj, and we have come to this conclusion. And he says, I've spoken to Dr. Sharan, we have come to this. So the family understands that internally we have had a chat. And we have now agreed with this. And so they are at peace to know that at least the relevant people have been involved in this, and that the best is being done for my father or son or whoever it is at the end.
And that is one of the major problem what family complains.
Yes.
The particular specialist says like this, another specialist say like that.
Correct.
Another person says like this. We do not know what is happening. One person saying So there the person who takes care overall as an in charge, though the reference is given to me, and to try to solve at that point of time will help definitely the patient. And
no question.
And that's where I feel happy that yes, I could address where others could not.
No, I agree. And that's why I had to also learn some medicine from experts like you, at least to understand what is being said, to say rather than say, I'm only surgeon, this all is my job. Because for me also, like you said, 50%, for me, neurosurgical care, neurosurgery, the surgical part is only 25-30% of our work. Rest of the work is all the perioperative care.
Agree.
Which makes the outcomes happen.
Yes.
Otherwise, the operation may go off great, but infection, something else happens, and it's an connected process. And patients want outcomes. They don't want surgery. That's when I realized that I had to put an entire system in place to make sure that we serve every patient well, the best that we can. Then his destiny will determine, his body's situation will determine what's. And one of the biggest things he helps me on is this tracheostomy. So can you speak just what is this tracheostomy? Just because I think very few would have heard. The people who have had a tracheostomy patient will know. Others, they may be hearing this word for the first time.
Yeah. So there are two things. One is about the misnomer about patient who goes on ventilator will not come out.
That's a new. We didn't cover that. Yes.
And the second one is about the tracheostomy. If you again do tracheostomy, they do not come out. So maybe the first part I will tell about the general concept in the majority is that in the majority of the population of the community is that ventilator ಹೋದ್ರೆ ಅವನು ವಾಪಸ್ ಬರಲ್ಲ.
Correct.
So
agreed. Agreed.
So that may be partly true. Generally, we put the patient on ventilator for the respiratory support till the underlying problem gets better. And there are many diseases where the underlying problem gets better, and obviously we wean them, either directly extubate them or subject them for a tracheostomy. But I agree with the general population belief that there are certain diseases where we feel that they may not improve. So hence they may not come out of the ventilator. In our knowledge, what we have gone through, maybe I can say there are many situations. Most of the situations will come back and they get better. They come out of the ventilator support.
I tell my patients' family, I've had patients on ventilator for 30 days, 40 days, 50 days who are back at work today.
Yes.
How many we have seen, Bas, right? Not one, not two, not three.
So hence that is a myth saying that somebody goes on ventilator, he will not come out. Hence do not put them on ventilator.
It's like a death sentence.
Yes.
And because of that, they're stopping them. And when we address this upfront, then they will say, sometimes they don't even tell us, the back of their mind they're having this.
So hence ventilator is not the death sentence. Ventilator is is to save.
Correct.
But over a period of time, we'll come to know that whether he's getting better or not getting better. But it also involves that he needs to stay. Finance also gets involved, which we need to understand from the family also. The next question comes what you asked about tracheostomy. So,
So what is this
yeah,
tracheostomy?
so generally the ventilator means we put the endotracheal tube. Endotracheal tube is through the mouth and through the speech box, what we call a larynx, and then it goes into the trachea.
Correct.
So that is the
Which is
windpipe or the breathing pipe. So it passes through the mouth into the speech box and then to the
Correct.
trachea.
Correct.
So obviously, whenever the tube is there in the mouth, and if the disease process gets better within next 3 days, 5 days, 1 week, we take out the tube directly.
Correct.
So what we call weaning from the ventilator and extubation. But especially
Even the tube is called
yeah,
extubation.
Yeah. So especially with the neurology and neurosurgery cases, they take longer period.
Long time.
That's when we call the weaning from the ventilator. Or if we keep the endotracheal tube longer, the number one, it causes more discomfort. More the time it is there in the pharynx, it will cause discomfort. We need to give them more sleeping medicine, sedate them.
Also, it can damage the voice box.
Yes. The second one is, yes, it passes through the voice box. The longer it stays, it causes more damage to the voice box.
Correct.
And the sedation requirement also becomes more and more. And the oral cavity, when the endotracheal tube goes from the mouth, the oral cavity care also may not be the good enough that what we continue to take care. Hence, there is a need of tracheostomy comes. Tracheostomy is nothing but making a hole directly into the trachea, into the windpipe or the trachea. Why?
Below the voice box.
Yeah, below the voice box. Yes, below the voice box. It obviously, number one, it reduces the discomfort that the tube is there in the mouth. Second, it helps to take care of the mouth better. Third one, since we are putting it below the voice box, so the voice box affects. The difficulty passing through the voice box, its stenosis or its damage also comes down. So that's what is the tracheostomy. That's what is the need. Of course, it has got its own complications and all. And the best thing with neurology, neurosurgery is for 7 days, 8 days, 10 days, they will not be able to breathe. They will be in the ICU. And one point of time, what I always say, that there is a one threshold line. After that, they start getting better, which I like, and I will be waiting for that threshold line.
I call it turning the corner.
Yeah. So
and it's a magical, Basavaraj.
Initially, I used to think, why Sharan is tells this turning this corner, he will turn. And yes, as I said, yes, over a period of time also, we do not know when the patient starts getting better.
Yes.
Of course, continue doing your work.
Yeah.
Work is
That's the key.
Yeah. So
that is the key.
And then the natural process or the disease process also gets better. And one point of time, like what I said yesterday, that patient Nagendra, wife, he was there in the other hospital, major hospital. Then he came here. Last 10 days, he has not spoken. So through the tracheostomy, I deflated, I blocked the cuff, and I asked him to speak. So he started speaking. The wife started crying. So wife started crying, saying that, okay, my husband is able to speak. So that is why it
How
helps.
much ever we say, until they see it.
Yes.
Seeing is believing.
Yes.
Otherwise, there's only so much that they can trust. Now, kannare nodbek, sir. That's what they'll say at the end of the day.
So, yes, we can make them speak during the tracheostomy tube. Amazing. And over a period of time, when they get better,
tears of joy.
Yes, we remove the tracheostomy and close it, and they are back to normal. What you have seen many patients coming back. So again, the second thing is, yes, if somebody needs a tracheostomy, if there is a good indication, and if the treating team feels that, yes, he can get better over a period of time, again, that is not.
And we can keep the tracheostomy for many months if necessary, until
many
they
months
get better.
We have seen for months and
yeah.
sometimes the permanent tracheostomy years together also, and they are doing a good job.
And permanent tracheostomy most commonly used for people with voice box cancer. But more, less than this, unless we have something going on here.
There is one patient actually who is a goldsmith. So he had a tracheostomy tube made from the gold. Yes. So he's living and he's walking with that. Because it causes less chance of infection and all. So he has made. Yes, it is.
My goodness.
And
it's
the
actual gold, huh?
Yes, and the family also is trained very well than any medical person, how to take care of the tracheostomy, how to clean, how to insert.
And he's in the community.
Yes, he's in the community.
He's gone back to work.
You come and he sits in the OPD, he blocks his tracheostomy and he speaks to you. Because he knows
amazing.
That will help. That the air passes through the vocal cord and then he can speak.
Rogi is better than Hosa Vaidya. It's Atra. It's like that. Very interesting. So now you see how much of a role somebody like Dr. Basavaraj and his team plays in helping us to give comprehensive management. And our entire team loves him. They go back and forth, dealing, with anything. He's very friendly, very affable, there's no issues at all. In fact, he's our family doctor. Even you heard him saving life, critical care, negative chemo, jara, even cold cough fever. We reach out to Basavaraj, and he's like the one-stop shop for us.
They might not have called you, and they might have already come to the OPD and say that
Correct.
I have not called. Was Sharan, he's busy in the OT, so I came directly to you.
Correct. That's how it is. So it's literally like we are, two brothers who work like this and go what is going on at the end of the day. It is fantastic how it is, because that's why I love chatting with you and doing what it is. So we never had, we didn't even deviate and talk about your personal life, and the public should know, because they think that you're a very successful guy. You must be coming from Jupiter, Mars. No. So can you tell us about your school, your background, where do you come from?
Okay, so yeah, nice that you asked me. So I'm very happy and proud to say that yes, I did my primary school in Kannada medium government school. It is called
Really?
as
Where?
it is in a place called Ramdurga. It's a taluka place.
Okay.
My father was a teacher and my mother is also headmistress for the high school. And there only the government school existed at that time.
No private schools at all.
No private schools. And it is called as Kannada Hiriya Prathamika Shale number 1. Number 2. So that also is written in the Kannada.
Correct.
But even now I feel that one of the best teachers what I have been gone through is our primary school teachers.
Amazing.
Who have taught us. And I keep telling to my daughter saying that ನನಗೆ ಫಸ್ಟ್ ಸ್ಟ್ಯಾಂಡರ್ಡ್ ಇಂದ 7th ವರೆಗೂ ಒಂದು ಕ್ಲಾಸ್ಗೆ ಒಬ್ರು ಮಾತ್ರ ಮೇಸ್ಟ್ರು ಇರ್ತಾ ಇದ್ರು ಅಂತ.
For everything.
For all subjects.
Oh.
Maths, English, Hindi, Kannada, Ganita, all you say. Only one teacher.
Interesting.
So that one person like Koludur sir, he's passed away. So I mean, he's an excellent teacher, and
amazing.
he
the
knows
unsung heroes that we say.
Yes.
Thanks to somebody like him, you are sitting where you are sitting, saving thousands of lives. Exactly. So amazing.
So I mean, they taught us very well. I mean, this thing.
I can really.
Yeah, and then I did my high school in the same college where my father was working. Ramdurgalle. And then for PUC, my father felt that okay, he should get a good rank. And meantime, I was playing table tennis. I had a breathing problem called asthma, the wheezing problem during my childhood.
I see.
And my father felt that if I get into the sports, I can get better. Correct. Because every time I used to go, and there was a doctor who used to give nebulization and one IM injection. And yes, it was a repeated going to the hospital and coming back. So then my father felt that he's good in sports. Then I joined a sports club. One of my sports coach, the Sangamesh Halyal, he also passed away. He taught me about the sports. He has also taught me how to live life, how to suppress and how to be aggressive, and how to fight back. So that's what the sports also teaches me.
Correct.
And my father felt that I can get a better education in Dharwad. So that's when PUC I joined in Dharwad, a JSS college, where we used to get a good ranks at that time. And meantime, I was playing a table tennis in one of the club called Cosmos Club. So I was a very good table tennis player, and I represented
You should play table tennis sometime together.
Yes.
Done that.
Karnataka. I represented Karnataka State also.
Oh.
I played once national games in Indraprastha Stadium, Delhi.
Oh.
So that was again, it's a past what I can say.
I don't know whether my dad knows this. My dad was a national table tennis champion.
Oh, is it?
Yeah, I should tell him. He loves anybody talking table tennis. He's like, deja vu.
Yes,
I should tell him this. He's asthmatic, he's table tennis. So you have got two things in common. I'll tell him this.
So that's when the sports also helped me that yes, you lose match, but again you fight back. And that is what the spirit, that saying that you are lost, but you come back. You cannot go and saying that no, I have lost. You cannot lose the confidence. True. And when you prepare for the next match, you win the next matches also. That helps in our overall growth.
Philosophy of life.
Growth also.
Again, my father used to always say when I was a kid, sports will make you a good loser. How to be a good loser and not lose it. And
accept.
Good. Yeah, accept it.
Accept
the mental health issue.
Yes.
Nowadays, the youngsters, many of them are getting into major mental health issues because they can't take failure.
Agree.
And that is another message Dr. Basavaraj is giving. Guys, failure is a stepping stone to success.
Yes.
All of us have had failures, but we have learned how not to allow it to impede us and actually help us to go to the next level.
And that's when I got a seat in medical college, JSS Medical College. I could not live in the hostel because of the financial situation. I stayed in a outside room, but yes, we enjoyed whatever it was. Good friends, as long as you are good, the other friends also, colleagues also will be good. There are some one of our close friend who could not get the MD medicine, so he went into the stressful situation and he lost his life also. And that's when other colleagues also felt that it's not the getting a seat or getting into
Not
good
the
position is not the life, but there is beyond the life also.
agreed.
Then yes, got into the medicine. I was into critical care. That's what got into critical care. I need to tell you also, yes, then I was working in one particular hospital both as a physician as well as the critical care intensivist, almost for a long period. And then I thought that yes, that is only my hospital, that is only my life. And because of various situations, I have to come out of the intensive care. That's when you were also aware that yes, I got in touch with you. Luckily, now presently I'm able to work as a consultant intensivist in one hospital and consultant physician in one hospital. And during that period, yes, even I was also feeling low, that because I believed everything should come from one basket, I should only be doing everything myself. Unless I go and work, it things will not work out. That's when my wife also gave me a good piece of support and knowledge. She told me about that story, about you
Which
should not
story?
about this you should not keep the eggs
All eggs in one
all eggs
basket.
in one basket,
Correct.
and how that mouse kept her his food at various
Correct.
aspect.
Correct.
And that's why I am able to take care of now 7 or 8 ICUs,
Oh,
because
so
it's
tell our viewers about that.
yeah.
I didn't know you're managing 7, 8 issues. Let them
Yes,
know.
yeah. So apart from me being as a physician, yes, I'm a intensivist as well as the
So you're an entrepreneur, say intensive care entrepreneur,
yeah, and yes, I'm
delivering quality care
Yeah.
where it doesn't exist.
exactly. And apart from me being as a physician, yes, I'm a critical care physician. I'm also the teacher for this post MD, post MBBS students.
Oh,
And the
really?
third thing is, yes, about I also felt over a period of time the corporate culture of intensive care should also go to the smaller hospitals which are in and around.
And can be more affordable.
Yeah,
Much
more affordable. And I used to work them as a locum doctor during my study period. So I know the hospital, I know the owners, I know the consultants there. And when I graduated from a critical care, so they wanted me to be there because I can show them the difference. It's not that I'm just taking care of the patient. I used
Correct.
to, there is a problem is there, I need to inform the management. So I
Correct.
want this to be done. I
Correct.
want this to be done. So they were
Correct.
happy.
Correct.
So building a ICU is a team, not only
Absolutely.
from the doctor's perspective, from the management perspective
Not
also.
building means not building.
Yeah.
The building is very easy to build. Getting that whole thing working
Yeah.
24/7 by 365. This is a 24/7 by
Yeah,
365.
so we have got a Plexus Criticare group. So in our group, we are around 40, 45 intensivists who are there, and we are managing almost around 8 ICUs over Bangalore. And yes, most of the ICUs after we have joined, and they also have done well. They are progressing well because ICU is the main backbone for the entire
I agree.
entire hospital. And it is the question is, it's not that yes, I am an intensivist, I need to be there within the ICU and then manage, but we need to come out of the ICU and be in touch with the specialist, be in touch with the family, be in touch with the management to decide things to improve. Because I believe that everybody is ready to improvise the system, but there are no connections.
Correct.
Or no connections is being told to them, because otherwise if I go and I do my job and come out, it may not be sufficient.
It's not enough. It's
Yes,
not enough.
yes.
Well said. It's not enough. So I'm very happy that you have put out. So you can see Dr. Basavaraj is doing so much more than his call of duty, all in the phase of making sure that quality life that gets delivered. And I think if we do as much as he can do, I know more lives will be saved. You just touched upon your teaching. You didn't tell much about the teaching, the courses that you run.
Yes.
Now you already have your hand, leg, go, pocket, everything is full. Now where did this teaching come into the place?
No, teaching is another thing which I told you that it helps me to learn myself.
That's right. You mentioned that.
Learns better, and then respect the students also, and respect their knowledge also, because their generation is totally different. and the way what we used to read and what they get knowledge is
Absolutely.
totally
We had
different.
no Google at that time.
Yes. For example, if I ask
So
one,
easy today.
yeah, one
That time we used to go
doctor.
to library, pull out this book, pull out that book, this page,
Yeah.
that page. Ella
Yeah, I remember I need to go to St. John's to see the journals, but now
Correct.
they have got journals in their in the
Yet they don't see. It's too
in
easy.
their hand. So we run a critical care course, what we call, through the Indian Society of Critical Care Care Medicine, what we call post MBBS critical care certificate course, and the second one is post MD, either medicine, anesthesia, or pulmonology. They can enroll into our IDCCM, that is Indian
Oh.
Diploma in Critical Care Medicine, and I'm the course. I'm the teacher as well as the course director for our hospital. And yes, as apart from bedside training to them, we also conduct the weekly classes to them, and I also help them apart from the medical knowledge. Some of it I also started telling about the non-medical things, maybe what I have not gone through about the finance management. So we discuss about the stocks, about the mutual funds,
Oh.
other things also.
Correct. I think your financial literacy is very
things,
important.
because what I have not
Very
gone
nice.
through. So, and they're interested and they're going through also, because some of the, if you have seen many of the conferences, the most topic discussed is this, and
Money.
that hall will be full whenever you
Correct.
talk about the financial aspect. Though I do not say that I'm good, but at least I have learned maybe a 5% and 10% over a period of time. But these younger generations are better also, because apart from just medicine, they need to be aware about how to deal with their life as well as the finance
Correct.
also.
Very important, because it's all part and parcel. If they have stress there, then they will not perform well here.
Yes.
So I think that balance. I'm glad that you're like a father figure for them, not just a teacher.
And the learning in the morning, I'm a early getter, which started with my sports and what I'd seen my father getting up in the morning. I think morning I started reading, learning, and that's when our communication goes to the students, because they are all worried today Basavaraj is going to send me this, that I need to prepare for this, is what happens.
They're waiting for your
yes
the message that comes. Oh, that was a fantastic chat, Basavaraj. I think it was such a free-flowing conversation on life, death, philosophy, CPR. I think we covered a range of topics. I don't think we have left anything else to discuss at all.
Yes.
So before I say thanks to Dr. Basavaraj, if you like this video, please make sure you subscribe to our channel, share this video and all the others that we have, and then hit the like button, definitely the bell icon, and then make your comments here, because we want to know what more you want to know. Suppose you want to know more from Dr. Basavaraj, you can write the topics that you want to us, and we can definitely call him back. Because if we keep talking, we can talk for another 7-8 hours for sure, or more, or so much more to talk about. But we don't want to keep saying something. That we want to hear from you guys and know what is going on. So thank you very much. Any last messages that you want to give your audience? 2 types of messages. Number one, as a critical care guy, physician, what is this one for anybody? Number two is either to prevent or in critical care. Secondly, as a physician.
Yeah. So prior to that message, again, I would come to about your neurorehabilitation. What I've seen is there is a tremendous time is given from your team to the patients, from the doctors, from the physiotherapists, from the various physio team that are involved, and there is a good success what I have seen.
Thank you for that.
But even in the community also, there are community people who are not aware that these things
exist.
Like for example, yesterday I was one of the best hospitals. Family had a problem that I'm unable to improve his speech. So then when I said that there is a speech and swallow therapists are there, so they are not aware where they are. I asked several people. So the people are also not aware. So we need to outreach our system also, that
Which
these
we
things
are working. That's where I need your help.
Which things are aware. And whoever needs, yes, neurology, neurorehabilitation, of course, as a medicine, I can vouch that yes, you are giving best services.
Thank you.
With your neuro services. And Dr. Sharan, if he gets involved, yes, he will get out of the best from the patient, what I believe. And with respect to the community, what I could say is, yes, it's again one who is working better. That work is worship, and the team wherever is working well, their, what I can say, their progress or their improvement, their prognosis will be better, what I could say. So this is what I want to communicate.
Fantastic.
So at the end, I would like to end up again with work is worship and the teamwork saves life.
I mean, you have demonstrated that very well. May God give you all the strength and more people to deliver all this to more and more people, because people like you are invaluable to the community.
And thanks to Sharan and PRS team and Dr. Pratibha and all of them that you could spend so much time with me, and yes, you could make me come out of so many things which I was also not aware that what actually all these things involves. Thank you so much, Sharan.
Our pleasure.
Thank you, Neuro Rehab team. Thank you, PRS team.
My pleasure. And before we finish, we have a customer think of giving a gift to all our, our guests.
Yeah.
The book that we have written, Rebooting the Brain. Please make sure you read it.
Thank you.
And give us your feedback, because this is only part 1. We have more to go.
No, I have gone through part of it already, which I feel it is very, very good. And it involves the medical as well as the non-medical things also, and how Sharan takes care of the neurology, neurosurgery, as well as the non-medical part also. Even I suggest all the viewers to read this and go through this, both for the medical as well as the non-medical person also.
Thank you.
Thank you for this book.
Okay, viewers, that's all from us. Thank you very much. Jai Hind.
Thank you.
So I wrote to many IITs, Department of Electrical Engineering or Electronics if it existed, the head of the department. Those days it's all, you have to write a paper, a letter and then send post it and get a reply if you are lucky after 10 days. The only one reply I got it from IIT
What did you
Madras.
write in that letter?
I said I'm trying for this thing. I have graduated and I'm trying for a MTech and I want to know how to prepare for your entrance exam.
Let me be honest. Did you really think somebody is going to reply to you? I'm asking you. I'm honest.
Yeah, if I didn't expect, then why would I have written to tell me? If you think it is foolish, that is what I told you, that is all I know.
I'm wondering which HOD will reply hundreds of followers.
One Professor V.G.K. Murthy, an amazing guy.
He responded, huh?
He circuits. He wrote in his hand. He wrote a nice letter.
Oh, very
These
nice.
are the syllabus, and you can prepare like this and all that.
Very nice.
And
From where? IIT Madras.
IIT Madras. So already I was sold to IIT Madras. This is the only person who replied to me. They care for people like that.
Correct.
No other response. But if I were you, probably I would have thought differently. But that time I was.
That is
the thing.
Original AGR.
So this is a man. This is the place I want to go, and I landed there. Senior professors are asked to give a lecture to the whole audience of institute. So not everybody gets that opportunity. So I got that opportunity. So
Where in
IISc?
IISc,
Did some few years back. So it's called institute lecture or something like that. So I said that research has 3 different types of people do 3 types of research. One is real research. One is imaginary research.
I don't know. You have to explain to us.
I'll tell you. One
have to.
One is complex research. Complex is not like it is complicated. That also is another meaning. Complex is like in mathematics, you will say complex numbers. Real plus imaginary numbers. Right? I plus 1 plus J2 and all that. You might have heard somewhere. See, what you talk about is real brain and all that. That's okay. But in research also, see, I feel we should work on real problems. Most allopathic doctors, you treat only head. Somebody will treat only nose. Somebody will treat only head, neck. But the body is a connected whole. When I breathe well, it controls my heart rate variability. It controls my brain signals. And there may be other things which you are not studying. So it's a connected whole, which is very much of interest to me.
No, I agree. Just to tell the viewers, see now, allopathy medicine is fundamentally a sickness medicine. You understand? Because when people are sick, they come to us. And I believe personally that allopathy medicine is strongest in surgery, emergency care, critical care, and those kind of stuff. And our job is to make the sick less sick. You understand? But wellness is not lack of sickness. I mean, not because you're not sick. In fact, if you look at the WHO's definition of health, it says health is a state of complete physical, mental, social, and spiritual well-being. and not merely the absence of disease, deformity, or infirmity.
So people do research to either get promotion or get funds from somewhere. So nobody is doing research for the passion. See, when C.V. Raman did research, he didn't get any great government funds. He was doing it during British times, and the evenings he used to come. He was an accountant. He used to come and work in the evenings.
Correct.
He was passionate to do something, learn something.
True.
That should be research.
And he got the Nobel Prize.
You shouldn't force everybody to do research. If you don't do research, I won't get you ascended persons. So everybody somehow wants to do some research, somehow publish something.
Correct.
So it has become useless.
Correct. I agree.
I feel that, see, I had great teachers in my BE and PhD tech. Nobody had PhD, but they were extraordinary teachers. You don't need everybody to be a PhD to teach. Teaching is different from research.
True.
So research should be only for people who are really motivated by learning to do something for the society. And
change
all
the world.
research should be applied unless 5% of the people maybe of the order of Einstein or C.V. Raman. Those people should be allowed to do some theoretical and pure research. Other people have to do applied research. It should solve some problem out in the world, whether for the medical world or some other vertical. I want to tell the youth, select a job that you are passionate about. This thing is about people living a fulfilling life.
Yes.
So take up a job not for money, not for something else. If you are really passionate and give whatever you have, in any profession, you can make money. You need to be a little smart, but that can be learned. At the end of the day, you should be fulfilled about what you did, and not become tired, I did so much. So don't select this thing. One of my Swamis whom I know, he said these IT people are, they keep jumping from jobs.
Correct.
So they said it's intellectual prostitution. You give a little more money, I'll just jump.